This is a very exciting time for us. As you all know, we're still really big on cutting edge and underutilized treatments such as clozapine and long-acting injectables, which we'll talk about this morning. We also have our keynote speaker, and I have to say, Dr. Rajiv Tandon, he's been struggling with cancer, and he wasn't able to make it today. So we have a small change in our agenda. Dr. Matcheri Keshavan is going to deliver basically the same lecture for all of you. So, please keep Dr. Tandon in your thoughts and prayers during this time.
This was a recent diagnosis. We didn't know about it when we scheduled them.
Yeah. This is a pivotal moment for Cures. Again, this is 10 years for us. We need to decide where we're going and, grow and prosper these programs that we're so proud of. Programs like our Caregivers Mentoring Program that you all heard about last night, our monthly Ask the Doctor, our CURESZ Clubs. So I'll be giving a lecture actually today about my own story and how the clubs could have helped me. We're working on a new strategic plan. If anybody's interested in receiving the plan, we'd be happy to share that with you. As I mentioned last night, Day Zero Toolkit. When this summit ends, Nicole and I and our wonderful designer, Eric Ayler, who is here, will be getting very, very busy to make a paperback version of Day Zero. As we're going to talk about today, it is so common for people to be discharged from a hospital with very little information. A little bit of logistics. You guys all have notebooks and pens. Enjoy. Uh, we're going to have photos taken today. So if you came, you kind of, automatically consent to photos. So thank you for that. And if you're interested in doing a testimony about cures, to be on record, our videography, Cody Green, is downstairs in a room. It's to the right of the stairs called the Big O room. He's going to be there most of the day. So please spend some time and record a testimony of what Cures has meant to you. We recognize our partners. We have Ingrezza here, Nami and Straight Talk with Daryl and Kristen Herman. Please check them out. Daryl's giving free books. So please pick up a copy or two. I know he has a lot of them. I know he'd love to share them with you. Let's see. Oh, and just a couple more things. We have a quiet room downstairs. If you need to get away, relax, there's some very comfy chairs. It's called the Neil Armstrong room. We'll talk about parking as you guys are leaving. And finally, you all at your table have two QR codes, all right? One of them is for the survey. Tell us very honestly how we did. Don't hold back. The other is for donations. So as I mentioned last night, we have donors that are matching your donations up to $10,000. We shared this with our board members and a couple of our donors, and a few people who couldn't be here today donated. Dr. Stephen Rush, 500, Dr. Danielle Johnson, 250, Kate Warburton, 250, and the Yeiser family donated 500. If you want to donate, I'll keep my eye on PayPal, and we'd be happy to announce your donation and add you to the sponsors that were up a little while ago. Anyway, any words, Dr. Nasrallah?
Thank you, Bethany. Good morning, everyone. Welcome again to this birthday party. I mean, we call it Summit, but it's actually a birthday party because we established Cures. It was born in July 2016. And it's really an act of love. Like Bethany and I decided, especially Bethany, who has a lived experience of why can't more patients suffering from serious mental illness like schizophrenia receive the latest cutting edge medications. In fact, today you're going to hear three presenters, including myself, talking about vastly underutilized medications. Like Clozapine, Dr. Cotes is going to talk about that. I'm going to talk about long-acting injectables, which are also vastly underutilized, and Tardive dyskinesia. The medication has been on the market for 9 years, and very few people are getting it. It's just incomprehensible to me. Just like Clozapine, why isn't Clozapine used to help people recover and get cured like Bethany did in 2008? It's really befuddling. So I hope that you will spread the word and encourage you, the psychiatrists or nurse practitioners who are handling your loved ones with schizophrenia, to consider using medications that are customized for their condition. So without further ado, I want to just tell you how incredible Bethany has been. Like I said, she was cured in 2008 when I gave her Clozapine, and she wrote a book about her recovery, which you can see at the table there. And last year we published another book called Awakenings to inspire both families, patients, and mental health professionals to never ever give up on patients with schizophrenia, because like Bethany, when Bethany was hospitalized after being homeless for a few years, and she was diagnosed as schizophrenia the day one by the psychiatrist in Los Angeles. He called her parents, who immediately flew out to LA and had a reunion with her after not seeing her for 5 years. And the first thing he told them, took them aside and told them, Bethany has schizophrenia. She'll never be able to go back to college. She'll never be able to hold a job. Take her back to Cincinnati, put her in a group home. Can you believe this? After seeing a patient with schizophrenia for one day, already written her off. A lot of clinicians in this country are doing that. Don't ever let them do that, because she proved them wrong, came back to Cincinnati, got cured, graduated with honors in molecular biology. This is what and she has been the president of the foundation for a good reason, because she spends hours and hours every day for all those years organizing and publishing and contacting and advising and organizing. It's unbelievable how hard she works. I want to give her so much credit for this meeting too. I mean, she put this on her own, like, with the help of mom and dad, who are sitting over there. Wonderful parents.
We'll recognize later.
Yeah, wonderful parents. So it's not easy putting together a meeting like this, but Bethany did that with the help of some people on the board as well. But I tell you, it is really inspiring to see how much Bethany has done, and a lot of patients, loved ones that you have, we call them patients, some people call them clients in mental health centers, can actually do more and have done more. And the Awakenings book that we published, again, I encourage you to read it. It gives you stories of 28 patients who were probably written off as well, and who are now fully functioning with jobs and professionals and all of that. So I hope that this meeting gives you hope, gives you information, and gives you an impetus to expect more from the clinicians who see your loved ones.
It is my absolute pleasure to introduce Dr. Matcheri Keshavan today, who is our keynote speaker. He's a Stanley Cobb Professor of Psychiatry at the Beth Israel Deaconess Medical Center, Harvard Medical School, a position he assumed in April of 2008. It's been a long time. He is also the academic head of psychiatry at BIDMC and a senior psychiatric advisor for the Massachusetts Mental Health Center. And finally, since 2017, he serves as director of the Commonwealth Research Center at BIDMC. Thank you, Dr. Keshavan. Take it away.
Thank you, Bethany. And can everyone hear me in the back there? Okay. So good morning. It's my pleasure to be the pinch hitter of this morning. So Dr. Tandon, as Bethany mentioned, was advised not to travel because of his health condition. But I want to tell you he is well, and in fact, he was fully engaged in an all-day meeting that we had, which I'm going to tell you about. So the other thing I want to say is Bethany, asked for testimonials, and I would say much, or if not all, of my talk is a testimonial to CURESZ and Bethany and others who are partnering with us in the field, who are also attempting to help cure schizophrenia. So with that as the background, what Rajiv Tandon had planned and what Bethany and Henry Nasrallah had asked for was a presentation to talk about where we are in the field of schizophrenia, what do we know and what we don't know, and how do we bridge that gap between known and the unknowns, if you will. And of course, you see Rajiv there with his beautiful smile, and then you have Dr. Henry Nasrallah, who are, I consider this as a joint presentation by the three of us. And you don't need to see my picture there because I'm right here. So, so if you go to the next slide, let me see how I can do that. Yeah. Okay. So the key goals are, today is the 10th birthday of CURESZ, and it is such a pivotal birthday because at this summit came together another very important event, and that is our colloquium. Over the last 30 years, Dr. Tandon, Dr. Nasrallah, and myself have been developing a series of what we call colloquia. Colloquia is a Greek term, goes back to probably 2,500 years ago, where people would get together and brainstorm, kind of shout at each other, but yet learn something new. And that's exactly what we have been doing. And in fact, I have to say, Henry calls us the three musketeers. Myself, Rajiv, and Henry. Every Sunday afternoon, we get together and discuss about the problems of schizophrenia and how we can address them. And with that in spirit, yesterday we had a summit in this very location with nearly 20 experts on schizophrenia around the world, a number from Europe and the majority from the US, about half of them in person. And we discussed about how we should be defining and diagnosing schizophrenia. And I'm going to give you a brief summary of the various colloquia that we have been part of and what came out of yesterday. So again, the goal is to talk about the knowledge gap that I mentioned already. And this is the kind of summary slide of the various experts around the world that over the years have contributed to this thinking process. You will see that brain picture with puzzles throughout my talk because we have had several colloquia over the years. And I'm going to tell you more about the ones that we have had in the last 3 to 4 years. And in particular, we are grateful to CURESZ Foundation for being our partner in these colloquia in the last few years. And of course, the colloquia in the recent years have also been supported by the Beringer Ingelheim and also Schizophrenia and Psychosis Action Alliance and so on. So this one paper, which was the most cited paper in schizophrenia research 2-3 years ago, came from one of our colloquia in 2022, where we asked ourselves, what do we know, what we don't know? Can we create a composite paper, taking stock of all the knowledge and its gaps? And so this was the paper that was published in 2024. And the questions in those colloquia were, what do we actually know? What does it tell us about the nature of this condition? And how that knowledge and understanding can lead to optimal treatments? And, what are the gaps? And we'll get to that in the next few slides as well, including diagnosis and treatment, and how can we do the best that is possible today. So the key point that I'm going to make repeatedly here is that there are already many things we know about this illness, but there are many more that we don't know. So there is that knowledge gap. There is a second gap that I also want to mention, which is the implementation gap. There are a lot of things that we do know work, but are not yet fully utilized in practice. And two examples of that are clozapine and long-acting injectables. You are going to hear more about them in the coming hours. So very briefly, the 3-minute video clip was a perfect summary of what we know and how we think about this condition. And schizophrenia is a complex illness with multiple dimensions, a mixture of what we call positive symptoms, which is another name for psychosis, negative symptoms, which refer to lack of motivation and blunted affect, and cognitive impairments. So, in one of our papers a few years ago, we even came up with an alternative name. Of course, this is a debate ongoing in the field as to what's the correct name for schizophrenia. I understand that there was a active discussion last evening, which unfortunately I missed. But one that we proposed was the Concord syndrome. It refers to the 3 key elements of this condition: cognitive impairments, conation, which refers to negative symptoms, and reality distortion. So again, there are many other alternatives, and so the field has to come together and develop a consensus, perhaps working with large organizations like the American Psychiatric Association, and answer that question. It is an active debate. In fact, it was debated in the International Schizophrenia Research Meeting a few months ago. So if there are, we have written about it, and I can say more if time permits. It's a complex syndrome with multiple dimensions, and its onset is typically in late adolescence or early adulthood. And it's a disease with multiple phases to it. There is a pre-morbid phase before the illness begins, and there is a prodromal phase during adolescence when subtle symptoms begin to emerge, but not full-blown psychosis yet. And then there is a psychotic phase, and then there are relapses and recurrences, and then a more chronic phase. The illness often is chronic with remissions, with relapses and remissions, and often, unfortunately, incomplete remissions, even though a small number of people do fully remit and recover. And we don't know at this time how to predict who are the ones that will fully recover, who are the ones that partially recover, and who have much more protracted course of the illness. There is a tremendous variability in symptoms, illness scores, and outcome. And as I said, there are multiple dimensions with positive, negative, and cognitive impairments, but there is also the dimension of disorganized thinking, mood symptoms, and also motor symptoms like catatonia. The current thinking is that it's a multifactorial polygenic illness, just like obesity, hypertension, diabetes. Several hundred genes are involved. At last count, it's about 350 gene locations in the genome. Several environmental factors, including substance misuse, childhood adversity, life stresses, and so on. And I'm going to say a little bit about abnormal brain circuits. And clearly, it's a brain disease, as was mentioned in the video summary. At this time, the main treatment is antipsychotic medications, but they're only partially effective. About 70% of people they work, and about 30% they don't. And they do work both for acute treatment as well as for prevention of subsequent episodes. And psychosocial treatments are critically important as well. A quick brief summary of the genetics of this illness. It is polygenic and multifactorial, as I said. There are a small number of genes of large effect. Many of them might be genes that relate to immune mechanisms. Some of them relate to mechanisms of neurotransmitters, not just dopamine. Dopamine is only one among explains only about 2% of the genetic variation, or even less. But more importantly, other neurotransmitters like glutamate and GABA are involved and may have genetic contributions. There is a large number of small effect genes. We don't know, what particular level of risk each of them confers, but together they account for at least about 40% of the overall illness. And then about 50% of the illness is maybe related to multiple environmental factors, gene environmental interactions, and gene gene interactions. Okay, now I talked about brain circuitry abnormalities in this illness. So it's important to think of the brain as a collection of multiple muscles, if you will, multiple circuits. As was mentioned in the little video clip you saw just before, there is the CEO of the brain, which is the prefrontal cortex. When that is not working right, that is what explains the negative symptoms and the cognitive impairments. When you are thinking actively, where does your hand go? That's the front. When you are really not feeling well and the world is going, haywire, where do you pull your hair from? The sides. That's the temporal lobes, the limbic system. That is what might underlie psychosis. It's a very oversimplified version of the brain chemistry, but suffice it to say that positive symptoms may be related to the temporal and limbic hippocampal kind of problems, whereas the cognitive impairments, you see that red blotch in front, the prefrontal cortex working with some other circuits in the brain. And then there is a third component, which is what we call the reward circuits, which involves the lower parts of the brain like midbrain going into the limbic system, and that might be altered in negative symptoms lack of motivation, flat affect, and so on. So that's the current 1-minute summary of the brain chemistry alterations in this illness. So we talked about what are the gaps in our knowledge. Even though there have been impressive advances made in our knowledge of the brain and using molecular biology and brain imaging techniques, we still do not have a diagnostic test for schizophrenia. There is no one mechanism that is sufficient to explain all of pathology in this illness. There is no one cause that can explain the etiology of the entire illness. And partly this may be because, as we were discussing yesterday in the summit, schizophrenia as we know it is probably not one disease. It's a collection of multiple diseases. And you can't think of one brain mechanism or one cause. So it is a collection of multiple illnesses. And simply because it is such a diffuse syndrome, it's hard to develop a diagnostic test. And I'll suggest some ideas into the future how that complexity can be reduced going into the future. And improvements treatments are effective, but the benefits are moderate to modest. And improvements have been happening in the field, but these are incremental. There have not been dramatic paradigm shifts yet, but they probably will happen, in the years to come. So just to give a very quick summary of this, where we are with schizophrenia is like that half full glass. We know quite a bit, but there is much more to do. And this is a summary picture that we came up in that 2024 paper, where we all thought about what's the best metaphor for schizophrenia. And what we came up with was that what you see in the back shadow of that picture, the elephant in the room, which many people might feel different parts of the elephant, like this old parable of the 6 Indian men feeling different parts of the elephant and coming up with the different interpretations. One feels the trunk and says it's a tree, another feels the body and says it's a carpet, and one feels the ears and says it's a fan, and so on. So the way we have been thinking about schizophrenia is like those blind men looking at the elephant in the room, in a dark room. So what we need to do is to develop a conceptual, a comprehensive understanding of this illness, which may have many components to it. From a causal point of view, genetics are involved, environmental factors are involved, and they interact. And what underlies the illness from a pathological point of view is a dysregulation or a faulty development of synapses. And this is, we have written about this maybe perhaps because in people at risk for schizophrenia and those who do have it, there is an accelerated loss of synapses during adolescence. And that is what might explain cognitive impairments and psychosis and negative symptoms. So this is a kind of a broad overview of how we think about this illness. It may be that this is one elephant or multiple elephants. We don't know. And that is where the field should be going towards. The key unmet needs in the management of schizophrenia are, number one, as I said, about 30 to 40% of people with schizophrenia do not adequately respond to dopamine blocking antipsychotic drugs. And antipsychotic drugs that we now know do not work for negative symptoms. Psychosocial treatments do, but medications at this time we do not have for negative symptoms. Similarly, for cognitive impairment, cognitive remediation works. Think of the brain as a set of muscles. Exercising the muscles with cognitive training works, but medications do not work. But there are some aspects of medications that may be helpful, which I'll mention in one of my next slides. Treatment non-adherence is a big problem. And part of the treatment non-adherence is because of a fundamental nature of the schizophrenia illness, which is what we call anosognosia, lack of insight. That itself might lead to non-adherence in many individuals. Poor physical health, medical comorbidity is a substantive problem. People with schizophrenia live 10 to 15 years less than people without the illness. Why? And this is because of an accumulation of medical complications, medical illnesses throughout the course of the illness. We have shown that people in the earliest phases of the illness are already more medically ill compared to their healthy control participants. And the number of medical illnesses expands over time in a much steeper way than in healthy individuals or even family members of people with schizophrenia, suggesting that illness itself and lifestyle might contribute to some of that medical comorbidity. Delays in diagnosis, which is what makes it difficult to intervene early, is an important unmet need. Medication side effects, tardive dyskinesia, and so on. And finally, importantly, stigma and therapeutic nihilism. Dr. Nasrallah mentioned about how, and Bethany, about how, statements were made by treatment providers that this is not going to get better. So that is a very common thing that we hear. Nihilism, pessimism, and that's a big issue. So I mentioned about these colloquia that we have been conducting, and one of the major gaps in the field was the question of what is the chemical imbalance in schizophrenia. We have all been taught that too much dopamine is what causes the illness. And that we have known for the last 60 years. And then about 40 years ago, it was then thought that just dopamine excesses do not explain everything. Maybe there is a dopamine imbalance. There is too little dopamine in the frontal lobes causing cognition problems, and too much dopamine in the limbic brain regions causing psychosis. Great idea, but it still did not explain many aspects of the illness. So we had a series of discussions, and we developed the model that what schizophrenia, as we now know it, is probably a collection of multiple diseases which may present with psychosis. There may be a dopaminergic psychosis, there clearly is, but there are psychosis symptoms that can happen as a result of a problem with serotonin or with cholinergic system or with glutamatergic system and so on. So the picture is a lot more complicated than we originally thought about. So this paper was published just this week in the prestigious JAMA Psychiatry, and we're all very excited about that. And hopefully this will also kind of revise our thinking in the field that we need to think about a serotonergic psychosis, a dopaminergic psychosis, a cholinergic psychosis. And of course, there are autoimmune conditions which cause psychosis, like the NMDA receptor encephalopathy. And they all have different treatments. Now, NMDA encephalopathy does not respond to dopamine antagonists. Cholinergic psychosis, anticholinergic psychosis does not respond to dopamine antagonists. It responds to cholinergic agonists like physostigmine. And even in what we call schizophrenia, there may be a subgroup that responds to cholinergic agonists. For example, the latest introduction into treatment of schizophrenia, Cobenfy, which is xanomeline trospium, is a cholinergic agonist, muscarinic agonist. So it doesn't work on dopamine, but it does relieve psychosis. So just a shift in thinking, and this is very, very important for our field. Now, we also had a colloquium in Rome where we focused on early intervention. It's important to remember that psychosis begins in late adolescence. Prodrome begins in mid-adolescence. And even after psychosis onset, there is a period of untreated psychosis during the treatment delay. And during that treatment delay, there might be further progression of whatever the underlying pathophysiology is. So early intervention is critically important. And how to intervene early, there are many efforts going on in the field, including studies funded by the FNIH and the National Institutes of Health called the AMP studies, which we are a part of, that is trying to understand whether there are novel medications that can be developed and introduced in the prodromal phase of the illness itself. So we are currently conducting those studies. In the Rome meeting, we also discussed about the concept of disease-modifying treatments. Now, dopamine antagonists are like giving painkillers to someone with rheumatoid arthritis, but they do not change the underlying inflammation. So one needs to address the disease process itself. And the disease process is not just dopamine excess, but involves developmental brain abnormalities, synaptic alterations, multiple neurotransmitter dysfunctions, and also psychosocial factors leading to brain change. All of those need to be addressed, and in addition to simply medications. And this is a complex slide which we published last year, which points to the importance of knowing the pathways to recovery in psychosis spectrum disorders, which include not only the disease process itself, but also several psychosocial factors and prior disease burden and the medication and the treatment burden itself. They all might combine and conspire together to produce the conditions that we see. So treatment has to be comprehensive and multifaceted. So, again, we had a Boston meeting in December of 2025, where we really kind of, you know, put our minds together to take stock of what we know and what we don't know, and what are the key, steps for the field forwards. And dopamine antagonists do, and at this time, partial agonists, and more recently, muscarinic agonists are the principal medications. They significantly improve some symptom dimensions, but have mixed effects on mood and motor and negative symptoms. And relapse prevention is critical in limiting decline. And what we do know is that preventing the second episode is such a critically important thing for the field. And clozapine is the one drug that has been shown to be superior in preventing the second episode. And for that reason, it has been a recent recommendation by the field to introduce clozapine much earlier, and I'll mention that in a moment again. And a range of evidence-based psychosocial treatments, including cognitive remediation, CBT, are effective in improving function. So we have to accept the reality that psychoses are heterogeneous, and the clinical and etiological definitions of the diseases likely do not exactly match with each other, so that we had to be agnostic to the current diagnostic approaches. And while we know a lot, we also don't know a lot. And research is needed for kind of really critically thinking about this concept called schizophrenia and breaking it down and consider whether there is another way of thinking about this as a syndrome, as a collection of different entities. And again, we summarized the key goals of early introduction of clozapine, measurement-based care, which we don't do. If you have a medical problem like high blood pressure, you go to your PCP, they will never even let you see the doctor until your blood pressure is taken. But you don't do that in psychiatry. We don't measure their cognition. We don't measure their symptoms, so on. So again, treat modifiable risks like cannabis. Establish multidisciplinary teams like coordinated specialty care. That's a new concept that is emerging. Individualize the assessment and treatment, and address stress tolerance and social determinants. We'll come back to that also in a moment. Destigmatize communication. Avoid hopelessness and therapeutic nihilism, and use existing treatments more effectively. There is this big implementation gap that we have to address. So there is a robust body of facts on causation, pathology, clinical features, and treatment. And so in the Boston Summit, we talked about the need for developing ways to understand the boundaries of schizophrenia, which are fuzzy, and also understand the components within this illness. So again, I keep coming back to what we know, and that those that need to be implemented more widely. Firstly, early recognition intervention, appropriate psychosocial interventions, enhancing medication adherence, long-acting injectables, and minimize agents that may worsen cognition. And we have written about this quite a bit. There is not only pharmacological additions, but there are pharmacological subtractions that we'll have to make for many of our patients. Many of them are on anticholinergics unnecessarily for years and years. They are bad for cognition. Simply taking that away improves cognition in many people. And then consider earlier use of clozapine. I want to mention here Rob Lightman, who developed this ease model for early introduction. Early introduction itself, assertive monitoring, slow titration, and engaging with the patient and family. So Rob is here, and I'm sure he will say more about this during the meeting. Now, yesterday's key takeaways. We had about 20 experts from around the world. The first is that the DSM and ICD, which we are the Bibles for psychiatric diagnosis have limitations. They have improved reliability, but they do not have validity. They do not at least not adequately enough. We need to know a lot more about, while we know a lot more about brain alterations and causal risk factors, there are no diagnostic tests. And researchers are actively engaging or developing ways to incorporate biomarkers into DSM and ICD systems. New efforts are likely to incorporate cultural, social, and environmental determinants of health. And Nitin Gokte was here yesterday. He is the head of one of the committees at the American Psychiatric Association, and Diana Clark was there. She was also a leader in the APA, and together with another the NIH person who is here, there was the proposal that was made moving beyond symptom-based classification by two different ways. A dimensional way using an approach called RDoC, research domain criteria. Bruce Cuthbert, who is one of the leaders along with Tom Insel, who developed that from the from the National Institute of Health. He was there yesterday, and he reviewed that. And also Brett Clements, which I'll talk to you in a couple of slides later, who in our group has developed a biological way of classifying psychosis. And Jay Shaw was one of our own trainees who then became a professor in Montreal, has developed a way of staging schizophrenia and other disorders. Just like we stage hypertension or different kinds of cancer, there is potentially an emerging way of staging this illness with stage-appropriate treatments. And also there is this big question in the field as to how and if the so-called prodrome or the clinical high-risk state should be incorporated into DSM going forward, DSM-6, if you will. And Bill Stone yesterday was talking about that, and so that's another area of active investigation and thinking. And also there is an effort, Stefan Leucht was there, and Wolfgang Gabel from Europe, who were talking about how we can bring the world together by bringing DSM and ICD to talk to each other so that they use the same criteria. So that's an important discussion that's going on. So this is Diana Clark, who wrote there was an influential series of papers in the American Journal of Psychiatry earlier this year. And Diana Clark is leading the effort to bring in not only symptomatic diagnosis, but also quality of life, symptom severity, and functioning as components of a diagnosis that we make going forward. Dost Unger, who also leads one of the biomarker committees in the DSM, was there yesterday, and he was talking about the need for incorporating biomarkers, such as CD-active protein, for example, inflammatory markers, brain imaging, cognition, electrophysiology, and so forth into DSM as we go forward. Another important goal for the field is not only to understand the biology, but also the socio-cultural context in which the patients come to us. So in understanding the diagnosis, we also need to understand the social determinants of the individual's illness. And Nitin Gokte, who also leads one of these efforts in the APA, was there yesterday and was talking about DSM's plans to incorporate them into our diagnostic manual. This is Bruce Cuthbert, and this is the RDoC model. RDoC basically refers to understanding an illness at multiple levels, at the molecular level, at the cellular level, at the circuitry level, and at the behavioral and social levels. And this is at a research level at this point, but eventually the goal is to simplify it in such a way that it becomes part of our diagnostic approach. This is Brett Clements, with whom we've been working as a part of a consortium across the nation, where there is an approach to agnostically look at psychosis instead of using DSM diagnosis, whether we can simply look at their brain's physiological signatures, whether we can identify different subtypes. And we have been able to identify 3 biological subtypes of psychosis, which may not at all map to DSM. The brain doesn't read DSM, so to speak. So there may be brain subtypes of this illness, which may help us eventually to change the name of this condition as we go forward. So the key points, as I come to my last slide, is there has been an incremental increase in our knowledge of the nature, causes, and brain mechanisms of schizophrenia. However, there are many unmet needs in how we diagnose and treat this illness. Major efforts are underway to develop diagnostic systems that better capture the biological, psychosocial aspects of this illness to inform comprehensive treatment planning. Improving understanding of the biology of schizophrenia will lead to better and novel treatments for this illness. Progressive in understanding and treatment and advocacy requires partnership. It requires partnerships between providers and researchers, as well as people with lived experience and family members and other stakeholders, just as what this meeting truly exemplifies. So this partnership is what will lead to progress, and I think there is reason to be very optimistic about this illness, and for all of those who are invested in caring for or suffering from this illness, I think better days are ahead. Thank you.
So you heard a kind of a sweeping overview from Dr. Keshavan. I'm going to be specific about 2 conditions. One of them is the most serious neurological complication of antipsychotic therapy, which we call tardive dyskinesia, for which we finally have a treatment. I spent several years doing research on tardive dyskinesia with no discovery whatsoever. It was very frustrating. So I was delighted in 2017, as I'll show you. A company called Neurocrine, I think they have an exhibit over there. In April 2017, they came up with the first FDA treatment, which was a thrill for me, because this disorder really ruins the lives of patients because of movement disorders that are very embarrassing. I'll show you some examples in a minute. So I'm going to give you a quick overview of tardive dyskinesia, and hopefully you'll find it useful. I'm going to divide my time, have 2 presentations back to back. I'm going to stand on this end for this one, and then I go to the other end, out of fairness to the audience, So let's get started. So tardive dyskinesia, the name tells you what it is. It's tardive, means late. Dyskinesia is a Greek word for movement, abnormal movement. So it's late onset movement disorder. It's not the acute EPS that you see right after you start an antipsychotic. And actually, we use antipsychotics now in millions of people. So the rate of tardive dyskinesia is going to continue growing. We use it in major depression as adjunctive therapy, of course, in schizophrenia and bipolar disorder and autism, Tourette, and agitation and dementia. So the distribution of the symptoms are very different than the acute EPS, extrapyramidal side effects, as we call them. It starts in the face. We don't know why, but it starts with the mouth and tongue and cheek and chewing and pouting and puffing and jaw movements and a lot of blinking. A lot of blinking means there's too much dopamine in the brain. This is the opposite of acute EPS, where they look like Parkinson's disease. They're very rigid and they stare at you. That's low dopamine, which happens immediately after starting an antipsychotic. But over time, the brain compensates, and I'll tell you in a minute how, and it became hyper dopaminergic. Too much dopamine causes all of those symptoms. But then it spreads. After the face, it goes down to the arms and the fingers, non-stop, moving, playing piano in the air. And then it goes to the trunk and the lower extremities. And you can see the foot tapping and toe movements all the time. It was first discovered, recognized at least in 1957. Remember, the antipsychotics were discovered in 1952. So within a few years after they started using it, they noticed there were different movements coming. They had no idea what it was. And eventually, in 64, finally gave it a new name, late onset movement disorders. And from then on, it became a major problem. 50% of people on Haldol, the older antipsychotic, which I hope none of your kids are taking, Haldol is a very strong antipsychotic, but it causes a tremendous number of tardive dyskinesia. There are other tardive syndromes besides tardive dyskinesia. You have I'm talking about this one today, but also there's tardive akathisia, tardive myoclonus, tardive dystonia, and tardive tic disorder, and tardive tremor. So all of these are neurological consequences of antipsychotics, sometimes without antipsychotics. But this is the one that we know exists in a lot of our patients. All right? So there are treatment factors that increase the risk of tardive dyskinesia. Obviously, the longer the duration, the cumulative exposure over time, the higher the risk. And history, this is very critical. The same patient who develops acute EPS, dystonia, rigidity, and facial expression and siluria and so on, are the ones who later develop tardive dyskinesia. It basically activates the brain to start compensating, because the brain hates it when you block dopamine. Dopamine is a very important neurotransmitter, by the way, for all of us. It has 5 jobs. Movement disorder, it controls movement. It's important in mood. If you block dopamine too much, you get depression. It's important for cognition. If you block it too much, you get dull and foggy. It's important in pleasure, and hedonia will develop loss of fun if you block dopamine too much. And number 5 is to keep prolactin normal throughout life. So the brain reacts when it loses. It's a very important neurotransmitter, and start increasing the number of receptors and making the receptors very sensitive, and that triggers movement that are beyond the control of the patient. They're involuntary. And so I kind of told you in advance what I was going to tell you later. And let's continue here. Another very important risk factor is mood disorders. People with the depression or bipolar are exquisitely sensitive or vulnerable rather, to tardive dyskinesia. We don't know why, but be careful. A lot of patients receiving antipsychotics, adjunctive therapy for depression, or antipsychotics for bipolar, especially bipolar psychotic, which is very common, they are at high risk for developing tardive dyskinesia. People who abuse drugs, patients who abuse drugs are also more likely. Diabetes increases the risk by about 10-15%. Females, a little bit more than males. This history of acute movement disorders I just told you predicts the tardive dyskinesia in the future. History of electroconvulsive treatment, although sometimes it is used for treatment itself. Older age, the older the patient, the more likely they develop tardive dyskinesia if you start antipsychotics at an older age. Presence of the dopamine receptor blocking agents, that's antipsychotics. You cannot diagnose tardive dyskinesia unless the patient has a history of taking an antipsychotic, because there are neurological conditions like Parr's disease, Mage disorder, basal ganglia calcification. There's a lot of neurological conditions that look like tardive dyskinesia, but you can't call them tardive TD unless there's a history of taking an antipsychotic. And moving along, the risk is quite high. Oops, excuse me. It's quite high in, I'm pushing the wrong button here. Laser. In patients who receive first-generation antipsychotics, which again I urge you not to use. It turned out they harm the brain in addition to working on psychosis. You don't want harm, of course. Second generation, with the previous exposure, you have a little less, but still 21%. And pure second generation is lower, of course, but not zero. That's why it's still a warning according to the FDA. Now, here's the fact that really bugs me. About 800,000 patients in the United States have tardive dyskinesia. Among the millions that take antipsychotics, That's a pretty high rate. Only 60%, only 40% are diagnosed, 60% are undiagnosed. Clinicians just don't recognize it, or they mistakenly call it acute EPS and they give them cogentin, which is very harmful. Cogentin makes tardive dyskinesia worse. It's used for treating low dopamine, but the TD is high dopamine in the brain. You cannot make it even higher. So, and even worse, 90% are not receiving the VMAT2 inhibitors, vesicular monoamine transporter. That's Ingrezza and the other drug on the market called Astero. They're same mechanism. Why aren't clinicians recognizing it? And why are, even when they recognize it, they are not using the available FDA drugs? It is incomprehensible. People are suffering enormously, biologically, psychologically, and socially. This illness, tardive dyskinesia, paralyzes people, keeps them at home. They're embarrassed going out. Their movements are so embarrassing to them, and their self-esteem is low. Physically, they cannot button their shirt. They cannot use the keyboard. They cannot eat properly, holding spoons and holding a mug. I mean, it is disabling biologically, psychologically, and socially, and yet they're not getting the treatment that would relieve them very well. I mean, my patients do great with one of those VMAT2 inhibitors. So now I'm going to show you some videos, mild, moderate, and severe, just so you get an idea what they look like. Andrew, please play the videos. All right, so here's a patient. Notice the movements in her face. She's maybe talking a little bit. What am I doing here? Sorry. Go down a little bit. So mostly in her face and her eyes. And those movements are involuntary. Okay, next video. This is actually a nurse who took adjunctive antipsychotics for her depression and developed mouth movements. Here's another patient showing you the mouth movements. Here's a man with mouth movements and finger movements down here. And if you hear the video, he has a very raspy voice. He's a young man who was diagnosed 2 years ago, and his movements are continuous. Why did that cut short? I thought it was a little longer. And next, I think you see another female here. Let's play the video. Again, focus on the face and some of the upper extremities, in the hands. Okay, tongue movements, lip movements, a lot of blinking. You can't help it. Goes on 24/7. And next, here's a more severe case. Okay, she has facial movements, mouth movements, finger movements, toe movements, trunk movements. This is what happens if you don't treat tardive dyskinesia. It's progressive. It gets worse and worse. This is why it's inexcusable for clinicians who recognize it and say, no, I'm not going to use the medication yet. Well, they're going to have a patient with more severe illness. That's, in medicine, that is the worst decision you can make. The earlier you treat, the better the outcome. Next. And here's even worse, this poor patient, nonstop. Facial movements, eye, mouth, jaw, fingers, toes, legs, trunk. Imagine being like this throughout your waking hours. And there's a treatment for it. Why is it not being used? I mean, I keep saying that again and again. It is not good medicine when you don't provide the patient with the medication they need. Imagine if this is cancer or heart disease. There'd be a scandal all over the place. Well, this is a life-destroying illness as well, and it's not getting treated. So these are the way we rate them on a rating scale called the Abnormal Involuntary Movement Scale, IIMS, and we add up the score. For FDA studies, you have to put a number, severity, and this one compare the placebo with the drug. That's standard operating procedure for the FDA. So what's the neurobiology? Like I told you earlier, well, over time, when you block dopamine acutely to treat schizophrenia, psychotic symptoms, or bipolar, or patients who have partial response to antidepressants, they give them. FDA has approved 5 different atypicals. They might develop tardive dyskinesia. Why? Because the brain starts compensating. Upregulation means it starts manufacturing more receptors to compensate for the loss of the dopamine signal. It's not getting a signal. And then it makes those receptors very sensitive. The slightest dopamine walking around in the striatum, which is the part of the brain that controls motor movements in the body, triggers a movement with no will. The patient is not initiating it like we all move when we want to. Tardive dyskinesia is not, it's involuntary. All right? So it's very different than acute EPS, which is really drug-induced Parkinsonism. They look very much like Parkinson's disease. If you hammer patients with a high dose of antipsychotics in the early stages, they look like Parkinson's disease. And it's because of low dopamine. But with time, like I said, tardive dyskinesia leads the brain to increasing the tone of dopamine in the brain, and that leads to involuntary movement that we call tardive dyskinesia. So how do those new drugs work? I wish I knew that when I was doing research. So these drugs, the VMAT2 inhibitors, work as follows. So when you want to move a muscle, dopamine is stored in vesicles in the brain. It's not hanging around the cytoplasm. It's stored for a reason. Because if they are here, they will immediately be destroyed by an enzyme called monoamine oxidase, MAO. So the brain hides its dopamine in vesicles, those spheres. When you want to move a muscle, several spheres go to the edge, they open up, release dopamine, dopamine stimulates the receptors, and you move a muscle. Neurotransmission happens. The same thing for thinking, for feeling, all of neurotransmission is similar. So what happens to the dopamine after the movement is initiated? The brain is very smart. It basically recycles everything and reuses them again and again. So dopamine is taken back up by a protein called VMAT2, vesicular monoamine transporter number 2. There's number 1 in the body, number 2 in the brain. So VMAT2 takes it back and stores it in vesicles, sticks it in there for reuse and again and again. Now, since dopamine is too high in tardive dyskinesia, VMAT2 is inhibited. These two drugs I told you about, like Ingrezza, will not let the shuttle bus, this protein, to take the dopamine, put it back here. It goes into the cytoplasm, cannot put it in the vesicles. It's how it's destroyed. So every day the patient's taking their pill, over 3, 4, 5 weeks, you see a significant decrease in dopamine because it's not being stored. It's being lost, it's oxidized, and the movements improve simultaneously. It's a very beautiful mechanism to reduce the hyperactivity of dopamine in tardive dyskinesia. All right, so in 2017, like I told you, valbenazine, which is Ingrezza, came out in April of 2017, and then another company introduced deutetrabenazine, which is called Austedo. Same mechanism of action. They happen to be approved by the FDA in the same year, and they both work in tardive dyskinesia. I'll show you just quickly the FDA study, one slide for each. So here's Ingrezza, valbenazine is the chemical name. Placebo, no improvement. This is a 6-week study, double blind. Patient gets pills. Nobody knows what they're getting. I don't know what they're getting. I do FDA studies. My patients are receiving a pill. We analyze, we break the code later. And you can see when the data is analyzed, the 2 doses of Ingrezza, 40 and 80, both worked very well, significantly better than placebo. And this has pretty robust effect actually, but 40 works in many patients as well. So that led to the approval of the drug. And FDA always cares about side effects. So here's the side effects. Very benign, I would say. The highest side effect is somnolence. Look at the small doses. Even with placebo has some side effects because patients believe that they're taking a drug, and we tell them in advance you may get side effects, so they're biased in a way. But these are single digits. This is ideal for in psychopharmacology. If you have single digits, that's great. And next, this is the other drug, deutetrabenazine. Again, compared to placebo, it works. So basically, it was approved by the FDA because at the end of the study, it was significantly better than placebo. And here are the side effects again, deutetrabenazine versus placebo. We always compare the two together. Again, these drugs are well tolerated, so there's no reason not to give them to patients. I've had a lot of patients take them, both drugs. I usually start with Ingrezza because it's easier to use, and for other reasons that no time to discuss here, but liver disease is a contraindication for this one, but not as and many of our patients have liver problems. So in conclusion, tardive dyskinesia is due to the chronic exposure to dopamine receptor blocking agents, which is another word for antipsychotics. And you know, you really can screen and distinguish them from other movement disorders. VMAT2 inhibitors can actually be very effective and reduce TD. But if the patient stops the medication, the TD comes back. It's like the other disorders in medicine. If you stop your insulin, your diabetes is going to come back. You can't stop insulin just because your sugar is normal. Blood pressure medication, you have to take them continuously. If you stop them, the blood pressure comes back, right? So same thing with tardive dyskinesia. It's not a cure, but it's a very effective management, all right? And we tell our patients not to stop it, otherwise the movements will come back. And then basically, these two drugs I described for you, both of them approved by the FDA, and you can use them if you diagnose the patient. I hope you do. All right, thank you for listening to the first presentation. My next presentation is about another vastly underutilized condition. Andrew is setting it up. Here it is, which is long-acting injectables. These are lifesavers for patients. Listen, we don't have a cure for schizophrenia yet, but we can stop it in its tracks by using guaranteed injectables, guaranteed that the medication reaches the brain without interruption, avoiding a second and a third and a fourth and a fifth episode, which many of our patients have, because almost none, 99% of clinicians in this country discharge patients on a pill. And we always start with pills in the hospital. Pills work great, but only in the hospital, where the nurses make sure the patient is swallowing it. So it reaches the brain, the patients get better, and most clinicians say, oh, this drug worked well, let's give a patient a prescription to take in the outpatient setting, without recognizing that they will never take the pills. They will stop it immediately many times, or within a week or two, for a variety of reasons, leading to a second episode. And many clinicians seem not to be aware that psychotic episodes are very destructive to the brain. They literally kill millions of brain cells. But we can recover from the first episode. There's enough reserve in the brain. But after the second episode, recovery becomes much more difficult because the brain changes. The receptors are not the same. The connection is not the same. The gray matter is destroyed. I'm going to show you the 6 tragic consequences of continuous relapses. So let's get going here. So I'll discuss the relationship between psychosis and brain atrophy, and well, of course, the tragic consequences of non-adherence, and how long-acting injectables really are a wonderful invention, discovery, to deliver the drug once a month, once every 2 months, once every 3 months. That's how, and forget the pills. We have to convince the patient to get on them. I like to start them the minute they leave the hospital with the first admission, first discharge. Very few clinicians do that. They discharge them on pills, and they get psychotic again. And the second episode again, they discharge them on pills. And after 3, 4, 5, 6 episodes, they say, maybe I should use a long-acting injectable. They miss the window of opportunity, which is to never even let them have a second episode and spare the brain destruction, which leads to disability. Let's continue here. So Dr. Keshavan already mentioned to you the 4 symptom domains of schizophrenia. And you can see the positive symptoms, negative symptoms, cognitive deficit, mood symptoms, and a lot of substance use. This leads to social and occupational dysfunction. Now, the antipsychotics work here. This is the 2 major unmet needs for schizophrenia. We need medications for negative symptoms and cognitive deficits. A lot of families contact me through CURESZ, telling me their kids are not psychotic, but they don't do anything. They sit around all day. They don't have the motivation to do anything. Or cognitively, they can't remember well. They can't plan ahead. They can't recognize what they should and shouldn't do. And over time, schizophrenia is a progressive neurodegenerative disorder. All right, so it starts in fetal life. Schizophrenia is abnormal brain development due to genetic causes. We have several hundred genes now. 80% of schizophrenia is now genetic. It's well established in the literature. And 20% environmental. including child abuse, by the way. Not only pregnancy complication during pregnancy that can disrupt the brain development of the baby. There are many conditions, infections, vitamin D deficiency, diabetes, anything bad that happens during pregnancy can disrupt brain development and lead to psychosis in the baby at 20 years after it's born, right? So it basically starts as abnormal brain development. And then when the illness starts, after the prodrome in adolescence, you get the first episode, and second episode and third episode if you don't stop it with long acting, and this becomes a biochemical dysregulation and brain tissue loss, becomes neurodegenerative, from neurodevelopmental to neurodegenerative. This is what's tragic about schizophrenia. You should stop it before it becomes more and more neurodegenerative, and then they become chronic residual phase. Most of our patients end up with unremitting delusions, hallucinations, because nobody bothers to give them Clozapine. Clozapine should be given after the first episode if the patient doesn't respond. After 2 weeks of antipsychotics in the hospital, first episode, and the delusions, hallucinations don't show significant improvement, Clozapine. Some clinicians wait for 6, 7, 8 different drugs before they give them Clozapine, or relapses. This is why you'll hear about Clozapine after the break. It can really change the disease-modifying strategy, like Dr. Keshavan said. If you use it very early, it can almost cure the illness in 50% of the patients. But nobody's getting it. 4% instead of 30%. Again, very tragic. But this is the life history of patients with schizophrenia. So from neurodevelopmental disorder, it becomes neurodegenerative with the onset of the illness. That's the beginning of degeneration, that's psychosis. Before that, there's no evidence of there's evidence of some inflammation in the brain during the prodrome, but not degeneration yet. And we didn't know until 25 years ago that the psychosis destroys the brain. So around 2002, that's when we started doing MRI scans after every episode and recognized the brain is undergoing atrophy. They didn't know that back in the 60s and 70s and 80s. They didn't give a damn about long acting because they didn't know how serious psychosis is. They thought this is schizophrenia. In and out of the hospital, that's schizophrenia. They never tried to use, even though they were introduced back 70s and 80s, nobody used them. They didn't want to impose on the patient. I let my patient make their own decisions. I'm sorry, the frontal lobe is the CEO of your life, as you heard. This is where you make decisions. The frontal lobe makes your wise decisions. And that's where you exercise your civil liberties. If your frontal lobe is not working, you're not going to make the wise decision. That's why patients don't know that. We do. The parents do. I advise many parents to become legal guardians of their children so that they can force them to take the medication that they refuse to take. It saves their life. It's compassionate to have a legal guardian for our patients. And then once they recover completely, they don't need the legal guardian. They recognize that they were sick. All right? So progressive atrophy in schizophrenia with psychotic episodes. This is an example of a patient. First episode here, already the ventricles are large. They're supposed to be like a slit. And so it means the patient lost some brain tissue. 3 relapses later, because the patient goes to different hospitals, ventricles are 3 times larger. Whenever the ventricles, which contains the CSF spaces, enlarge, it means you've lost brain tissue. When you lose tissue in your cortex, the ventricles enlarge. That's a proxy for degeneration. And 8 relapses later, the patient looks like early Alzheimer, basically. Ventricles are so huge, it means the patient has lost massive amount of brain tissue. That's why the patient got disabled. You should stop it right there. Don't let the patient lose any more brain tissue. But nobody is giving them long-acting injectables there at discharge from the first hospitalization. That, in my opinion, that is a travesty, because we know it can help. I know I've given it to patients, and they basically go back to college, and they go back to work, and they date, and they marry, and they have a life, because the medication never stops reaching their brain every day without taking pills. But nobody's using it at the right time. They're always late. I'll show you the data in a second. All right, so this was the very first study that actually measured what happens with the first episode. You can see here, patient lose 1% of brain volume in the first episode alone. The brain is 1,200 cc on average, so 1% is 12 cc's. Mostly gray matter, and the ventricles enlarge. So this was like basically the first study that has replicated many, many times now. And the patient's brain is shrinking and atrophying with every episode. And of course, they got disabled. Because you're destroying brain tissue, you cannot afford to lose even, I don't want to lose 1 cc. 1 cc of brain tissue has millions of brain cells and glial cells. I don't want to lose 1 cc. Patients with schizophrenia lose 12 in the first episode, another 12 in the second, and the third. After 4 or 5 episodes, they've lost 40, 50 cc's, like a cup of brain tissue. And you wonder why they're disabled? We should never let that happen. Stop it in its tracks. But many clinicians are not doing that. Inexplicable. All right, this is what I just told you about 12 cc's are lost in the first episode and how it kind of adds up with every episode till the patient has lost a cup or a pint of brain tissue. And an MRI scan study was done at NIMH in the adolescent section, and you can see they compared normal adolescents, because the brain changes with adolescence a bit, with patients who are adolescent with schizophrenia, males and females. And they color-coded every year. They did the MRI and color-coded the volume of the cortex. Okay? 5, you say? 5 seconds? 5-minute warning. I'll have to talk faster. As if I was not talking fast to begin with. So you can see on the left here, the annual loss, 1%, 2%, 3%, 5% per year. In other words, after 5 years, they've lost 20% of the parietal and temporal lobe and part of the frontal lobe. I mean, this is the dramatic change when you follow them up in research. Clinicians don't do MRIs, but researchers do, and then we share it with them. They should read the literature and abide. So Bethany and I wrote an article about how psychosis is really a brain attack. Just like we have a heart attack, it's a brain attack. You lose tissue, just like a myocardial infarction, heart attack. You lose muscle from the heart, dies forever, infarction. Same thing with the brain. Maybe we should change the word psychosis to brain attack. Maybe the public will become more compassionate and understanding of the severity of this illness. Thank you. And the causes for the brain destruction has now been tracked down over the last 20 years to 2 very destructive processes. A lot of free radicals are released in the brain during psychosis. These are very nasty molecules that chew up brain tissue, and brain inflammation. All the inflammatory biomarkers, we measure them, CSF and brain and blood, rise sky high during psychosis, showing that the brain is being burned and chewed. We should never let the patient have another psychotic episode, ever. So this is a study of neuroinflammation. Many studies have basically pointed out that neuroinflammation in the white matter is also damaging. Here's the white matter. It disintegrates during psychosis as well, which is critical because 60% of the brain is white matter. And one thing that should be recognized, prolactin goes up when you block dopamine. It's one of the jobs of dopamine to keep prolactin normal throughout life. Well, when you block dopamine, prolactin goes up. And many clinicians say, oh, it's a sexual side effect. Yes, some patients complain of sexual side effects. You can lower the prolactin for them a little, but don't lower it too much, because prolactin has multiple protective effects, including promyelination. It repairs the white matter and remyelinates it, which is badly needed after psychotic episode. You destroy the myelin. Without myelin, the brain doesn't work. All this connectivity. There are 200,000 miles. 200,000 miles of white matter fibers in the brain connecting all the regions together. If they're not myelinated, the brain is not working. It's disconnected. All right? So non-adherence is extremely common in patients with schizophrenia. Okay, the reasons are many. The most destructive aspect of schizophrenia is the lack of insight. This is so hard to treat an illness where the patient doesn't want to be treated because they don't believe they're sick. And so they refuse treatment. They refuse coming to the hospital. Thank God we have state laws that enable us to hospitalize them against their will. Otherwise, they would basically damage their life. We want to save their life by giving them the treatment. But anosognosia it doesn't go away, by the way. They get better in the hospital. Psychosis goes away, but their insight does not come back for many more months and sometimes years. So that is one of the main reasons they relapse again and again. Cognitive impairment as well. They forget, excuse me, they forget their, to do a lot of things, including taking pills. Negative symptoms, lack of motivation, avolition, Again, very, very bad for adherence. And side effects, patients think they're being poisoned because they have side effects. That's a paranoia, of course. And then vast majority of them are abusing alcohol and drug because they live in the community. It's impossible to take your pills when you're drunk or stoned. I mean, there are so many reasons patients keep relapsing. It's so sad, but there are many reasons for it. So recent advances have shown us that long-acting makes a big difference. The very first study was done by Dr. Emsley in 2008. He wanted to use a second-generation long-acting, not the old generation drug. So he got 50 patients recruited from the community. He told psychiatrists, send me your first episode patients. And they sent him 50. He started them right away with long-acting risperidone, which was the only long-acting available of second generation back then. And he published his paper. 2/3 complete remission. Remission means total absence of disease within 2 years. 2 years follow-up. He did a 2-year study. Basically 97% maintained their remission, and they get their insight by the time the study finished. So he sent them back to the psychiatrist who referred them. They were all put back on pills. This is South Africa, because that's the way they practice. They thought this is just a study, right? Well, 97% of them relapsed within a few weeks. See how they lost their opportunity to stay well? And not only that, when these psychiatrists realized that the long-acting injectable was better, they put them on long-acting. Too late. Already 16% who had responded fully for 2 years didn't respond anymore. Treatment resistance develops with every psychotic episode because the brain changes. The destruction of the brain prevents improvement. And later studies show that every relapse, you lose 15% stop responding. And eventually they all become treatment resistant and need clozapine. All right? So here's another study showing that first episode, you quickly, the improvement happens very shortly, within a few weeks. Second episode, longer. Third episode, much longer. With every episode, you have very long treatment resistance and long time before they show any improvement. Here's another study done at UCLA, where they discharged patients in the inpatient first episode, doing great on the pills in the hospital, because the nurses gave them the pills, of course. And half of them got pills, the same pill, half of them got injectable of the same antipsychotic, followed them up for a year, counted the number of relapses, and they published their paper in a major journal. And you can see 650%, 650% higher relapses in the oral group compared to the injectable group. Now, if clinicians read this paper, and I hope some do, many of them don't, wouldn't you give a long-acting to your own family member if they are hospitalized for a first episode psychosis, seeing what a difference it makes? It saves their life, but they still give them pills. So here are the devastating consequences of psychotic episodes. I think you recognize those. First, brain tissue loss. That's the heaviest biological price you can pay. Treatment resistance. They stop responding more and more. You need higher and higher and higher doses compared to the first episode where low doses work very well. Never again. With every episode, you have a higher and higher dose. Eventually, even the highest dose stops working. Permanent functional disability. They can't go back to college, go back to school, or work, whatever they were doing. Incarceration, which is a tragedy. This country, this civilized country, half our patients are in and out of jails and prisons because there's no more hospitals, state hospitals, to immediately admit them and treat them with dignity. They get arrested when they get psychotic, and they go to jail, and they become criminals, and they put them in prison next to rapists and murderers. They're treated like trash, all because we did not protect them with a long-acting injectable. They give them pills that they don't take. And then suicide. This is incredibly high. Many clinicians are not aware. Suicide in the first year of schizophrenia is 10,000% higher than the general population. They kill themselves in droves. And how do we know that it's because of psychosis? Because they drew the blood from bodies of patients who committed suicide with schizophrenia and found zero antipsychotic in their body. The lack of antipsychotics leads to suicide. And finally, homelessness and premature mortality. And we know that patients with schizophrenia lose about 25 years of life. Suicide, again, I showed you that earlier. Back very quickly. Never again. Second episode, because they stopped the drug. Now there's a lag. third episode, even a longer lag, and so on and so forth. And if you do MRI under each episode, you see the ventricles in red, enlarging, 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 like I showed you earlier. So basically, this is what I propose that psychiatrists do for patients with schizophrenia. After the first episode, they bounce back, like I said, start their long acting, and they stay well. They stay well. They regain their baseline. Whereas most psychiatrists in this country they basically give them pills and they relapse again and again and again. This is the way to treat schizophrenia, which is not being used in this country. Now here's a slide showing you the use of long-acting injectables in all the states. You see at the bottom, these are all the United States, 50 of them, and here's the average, 14%, red line. What a shame! It should be 70% because 30% need clozapine. But 14%, some states a little bit higher and some states lower. The average is 14%. And those 14% is after multiple episodes. Rarely do they get it after the first episode, like I'm proposing. So disability actually starts after the second episode. That's why it should be our goal. Never, ever let the patient have a second episode. It doesn't happen, though. All right? I think it's a disease-modifying step if you do that. And then finally, mortality. Patients die in many, besides suicide, they die from multiple heart disease and pneumonia and infections, you name it. They die because of their lifestyle and drug abuse and infection, lifestyle. They die very in high numbers. So a psychiatrist in Sweden, academic psychiatrists, decided to do a study to see, is there a difference in death rate from all causes with the various antipsychotics? Nobody had ever done a study to see if this drug or that drug has less mortality. So they kept 30,000 patients in Sweden. They have a single payer there on the same antipsychotic for 7 years. First generation, second generation, pills, injectables, and followed them up and counted the deaths. What did they find out? Absolutely the lowest death rate was with a second generation long-acting injectable. All the other drugs had higher and higher and higher death rate. So it turns out that injectable second generation saves their life, not just prevents the relapse. We use them to prevent relapses, obviously. That's the main reason. But they actually lower the death rate from a variety of causes. I don't know why we're not using them. Let me skip that and conclude. I hope you recognize the conclusion without me saying it. We need to give our patients more long-acting injectables very early in the illness. Thank you for your attention.
We actually do have a few minutes for questions.
Oh, we do?
We do.
I thought we were going to do it in the panel.
Well,
Okay. Any urgent questions? I can address them now. Dr. Keshavan maybe could answer some questions as well. Yes, ma'am.
So first episode.
Everybody can hear. Why don't you speak here so people can hear?
Okay, so I have a question about first episode when they're hospitalized. Do you start on an oral antipsychotic and then transition to the long acting? Okay, just to see how they do.
They're all approved by the FDA. But the reason we start with pills is to make sure they're not allergic to it. That's the primary importance. That they can respond to it and they tolerate it. Okay, and the nurses make sure they're swallowing it because some patients paranoid, they cheek it and spit it later. That's why they get better in the hospital. The nurses make sure it's entering their body, and then we switch them to long acting at the time of discharge.
So most hospitalizations are not longer than 2 weeks. So do you give them a 2-week trial before you go to the long acting? How long do you wait before you decide this is going to be a good medication that will work for them?
There is a principle in psychopharmacology that applies for both psychosis and depression, by the way. Patients who respond within 2 weeks, that's a very good sign that they're going to do well on that medication. If they don't respond to the antidepressant or antipsychotic in 2 weeks, that predicts treatment resistance in the future. So yes, I understand how short the hospitalization rate is in the country these days. And so at the time of discharge, because of managed care, it's unbelievable. When I was a resident, we had a month, average stay was a month. We saw patients improve significantly before they discharge. Not knowledgeable on pills, trust me, they're going to come back. And we see them in our emergency room here at University of Cincinnati. We have a large emergency room. They all come back relapsed.
I have a question.
who has a question? Oh, okay. I will come over and give you the microphone. Oh, does she?
Yeah.
Oh, good.
I had a question about tardive dyskinesia. You listed a lot of different types of tardive dyskinesia, but I didn't see one specifically about tardive blepharospasms. Is that rare, or could you talk?
Blepharospasm is not, it looks like tardive dyskinesia. It's blinking a lot, but there's no history of antipsychotic therapy. It cannot be tardive dyskinesia. They look alike, but blepharospasm is an independent neurological condition.
I have heard there's research about Abilify having a tendency to create tardive blepharospasms.
Tardive dyskinesia, I mean, aripiprazole causing blepharospasm, that's tardive dyskinesia. If a patient did not have blepharospasm until they received aripiprazole, yeah, I've had patients develop TD with all antipsychotics, including aripiprazole. Yes, ma'am. Then I got to go there. Go ahead.
Doctor, why isn't there a Clozapine injectable?
Why isn't there? Because you never know if somebody's going to develop agranulocytosis, which is Atlas says they will die. We have to do it by mouth so we can measure the blood level for at least the first 2 years, and then you can give them long acting, but it's not available yet. There's the medical legal consequences are huge, liability, so it's not going to be used. But it makes sense, right? But you know what? Once patients improve on clozapine, the adherence is remarkable, because we see them once a week to draw blood level. It's a way we check on them every week, which is much more than patients in the general population who have, psychosis, but they see their psychiatrist once a month or once every 6 months. So actually, patients on clozapine also die much less. A long-term study showed that they actually survive because they get good medical care as part of their ongoing monitoring.
So do you believe, sorry, subsequent question, my son did not respond to any of the other psychotics, including injectables, but only to clozapine.
Yes.
Clozapine was his savior.
The injectables are not as good as clozapine, because all the injectables are regular antipsychotics. They were great in patients who respond. 70%, you heard me say 70%? 70% of patients with schizophrenia respond to dopamine antagonist drugs. 30% do not, and we believe they are glutamate-related, different subtype of schizophrenia. There are many subtypes, there are hundreds of subtypes. The 30%, you're going to hear about clozapine from Dr. Cotes after the break. You can ask him more questions, but I hope I answered you.
Thank you.
Yes, ma'am.
Hi, I'm a retired pediatrician and a mother who will never retire. You talk about the premorbid and prodromal symptoms? Could you give me some examples of what that looks like?
Prodromal symptoms, yes.
Yeah.
Babies actually at birth, there's studies showing they tend to be floppy. As a pediatrician, milestones for the children in the first year of life, they tend to be delayed in patients who later become schizophrenia, walking later, talking later, smiling later. And then the prodrome starts 1 year before the psychosis in the teenage years, and they basically become more withdrawn. Not paranoid, but more asocial. They don't like to mingle with people. Their grades in school start going down. That's cognitive deterioration. And they start having like OCD symptoms, depression symptoms, ADHD symptoms. A variety of psychiatric symptoms appear during the prodrome. And the parents don't recognize that this is a problem. They think it's adolescence, they're unpredictable. But the presence of a family history, we call them ultra high risk. If there is a family history of schizophrenia in a blood relative, and the teenager starts showing those symptoms, that's a prodrome that's going to be followed by a psychotic episode within a year. But not all of them become psychotic. Follow-up studies show that some of them actually bounce back or develop other conditions.
Our next featured guest, who is a recent addition to our Cures board actually, is Dr. Robert Cotes, MD. He is a professor at Emory University School of Medicine in the Department of Psychiatry and Behavioral Neuroscience. He's chief of psychiatry at Grady Health System, founder and co-director of the clinical and research program for psychosis at Grady Health System, which is comprised of 3 different clinical programs, actually. His research focuses on clozapine, pharmacological and psychosocial interventions for people with clozapine, and also he deals with cardiometabolic side effects. So welcome, Dr. Cotes.
Thank you so much, Bethany. I'm just delighted to be here among you all. I'm so inspired by the work that the CURESZ Foundation does, and I'm so excited about serving on their board and supporting the mission. I've been working with CURESZ now for a number of years, answering some of the questions that come in about some of the medical issues, and I've really enjoyed that component of it. Today, I'm going to be talking about clozapine and xanomeline, xanomeline trospium, also called Cobenfy. So I work in Atlanta at Grady Hospital, which is a hospital for largely people who don't have insurance or who are underinsured. We are a public hospital, and I started working on the inpatient unit in 2011 there as the medical director in 2012. And there, I was surprised that really there was a lot of people that could have benefited from clozapine, but really people weren't on clozapine, and it surprised me. And in this large health system that I worked at, it turned out that we had about, I don't know, 5 people or so on clozapine in our clozapine clinic. And to me, that just seemed really surprising and kind of unacceptable. So I don't have to convince this audience of how effective clozapine can be. I mean, you all know this. You know, we see people living who can testify to just how important and effective this treatment is. So really, you know, at Grady, my main goal became to establish a clozapine program. And I've learned a lot over the years from people with lived experience and from organizations like NAMI and from CURESZ, and have, you know, thought a lot about the approaches and trying to be more effective and person-centered every day. So our clinic, this is a sad story. Our clinic was initially named the Treatment-Resistant Schizophrenia Clinic, the TRS Clinic. And this was back in 2012. And one of my patients was like, "What does TRS stand for?" And I was like, "Oh, no, it stands for," I couldn't even have, I didn't even have the heart to tell her. But we changed the name to PSTAR, which you see on the bottom right there, Persistent Symptoms Treatment, Assessment, and Recovery. And I don't know if that's the best name for it, but I think we've got to throw the term treatment resistance out the window. Because I think it leads to this nihilism that we heard Dr. Keshavan talk about. And it's very pessimistic, and people can certainly recover on clozapine. And really all it is probably a different subtype of whatever this heterogeneous thing called schizophrenia is. Okay, here are my disclosures. We're going to talk about clozapine. We're going to talk about access to clozapine. We're going to talk about the importance of early initiation of clozapine. And then we're going to talk about xanomeline and how that works, and compare and contrast clozapine and xanomeline a little bit and where their role fits in. And then we'll take some questions. So really, these are 2 breakthroughs for 2 very different problems. And I think that there's been a lot of excitement about xanomeline, the muscarinic agonist, and deservedly so. But the potential danger with xanomeline is that it may delay clozapine trials for people who could really benefit from it. So when we talk about the treatment algorithms in a minute, what I don't want to happen is somebody fails one dopamine receptor blocking agent, then they fail another, then they go to Cobenfy, then they go to clozapine. We've got to figure out how to get to clozapine sooner. Now, I think that xanomeline has great promise, and there's a lot of ways and a lot of scenarios in which it can be highly beneficial, and I've seen it in my own clinical work. But xanomeline, at least as far as my current understanding of the literature and its mechanism go, is not a treatment that's going to substitute for clozapine. Okay, so we all know it's almost impossible to find someone to prescribe clozapine in the United States. I get so many emails from family members searching for a clozapine prescriber in Georgia, outside of Georgia. The CURESZ Foundation with their prescriber locator tool, I think, has done a great job in helping. I know I've used that to help identify prescribers in other places. But really, this is a terrible problem, and there's a lot of state-by-state variation. And in fact, in the Southeast where I live, there's the lowest clozapine utilization of any other area within the United States. So I hear from a lot of people who are trying to get access to clozapine, and I hear from people who have been involved with Team Daniel, from CURESZ, from NAMI, all over the country, and they're looking for people, and it's just quite difficult. Like Dr. Nasrallah was mentioning earlier, really up to 30% of people could benefit from clozapine, and we're really only at 4% of people in the United States on clozapine. And the clozapine underutilization gap is probably 18%. And this doesn't even account for the people that could benefit from it as a way of reducing suicide risk or violent behavior, for that matter. So we did a study that was published last year that looked at facility availability of clozapine in the US. And this study uses a data set called the NSDUH, which is a national data set in which all psychiatric facilities report their data. And it's sort of inpatient, outpatient, ACT teams. And I thought when we set out to do this, it was going to be bad, but I didn't realize it was going to be this bad. And what we did was we looked at all the facilities that were prescribing risperidone as a sort of a comparator antipsychotic medication. And we found that, on inpatient units, where 100% of inpatient units should be able to prescribe clozapine, only 77% were prescribing clozapine. Inexplicable. We then looked at programs that had a serious mental illness program, that's how they defined it, that was 63%. And then on ACT teams, it was around 57%. So what this suggests is you can't even get clozapine, not just from a prescriber, but from an entire system in various areas. Could you imagine needing to be on an ACT team and having to go to a different ACT team that might actually work with clozapine? But I think that the opportunity here is that this can be kind of a report card for us about how do we do with increasing clozapine moving forward. This was done before the end of the REMS. This was, the government's usually a few years behind in the data, so this is from 2023. It was the most recent that was available for us to analyze. So I'm hoping that after the REMS, only one of the many barriers that we can kind of go back to this and see, are there any changes at the facility level? And right now, there's studies that are ongoing that my suspicion is that clozapine prescriptions might most likely haven't changed after the end of the REMS. I think it's made it much easier for people to get access to clozapine that are already on it, but there's still a lot of inertia around initiation of clozapine. So I think that for everybody in the room, one key thing is to hold our clinicians and accountable to what the guidelines are. Everybody, I think, in here can do that. And I'm going to talk about a number of different guidelines that you can reference. And, you can say, look, this is the most updated evidence. You can present it to a prescriber and say, like, this is kind of where we are right now. But I mean, this is sort of some basic level stuff of where clozapine fits in. There's 3 places in the APA guidelines where it fits in. The first is clozapine after minimal or no response to 2 trials of antipsychotic medications. In the package insert, that's called treatment-resistant schizophrenia. I'm hoping that this ultimately will change. And I think that this definition right here is part of the problem, because there's a debate right now around whether we should be using clozapine after one antipsychotic failure or after two antipsychotic failures. Once you get to two antipsychotic failures, prescribers like in the prescriber group, we begin to chase our tails around, is it really failure of two antipsychotics? Did the person get an adequate dose with an adequate duration? Remind me what the adequate duration is. No one wants to think that the antipsychotic trial has failed. We heard from Dr. Nasrallah, the key principle is after 2 weeks, if somebody's not responding, it's time to start shifting gears. There's pretty clear data from Europe around what happens when with people with a first episode get randomized to clozapine as the second antipsychotic or a different antipsychotic. And it's pretty clear that after one antipsychotic, maybe it's time to start thinking about clozapine. But again, whatever this illness is a heterogeneous thing, and we really need to be able to figure out a biomarker to help us identify clozapine candidates much earlier. I think that would help to settle a lot of this, does somebody meet the criteria type problem or not? Recommendation number 2 is the one that really people don't think about in the clinical world almost at all. This is for people with schizophrenia be treated with clozapine if the risk for suicide attempts or suicides remains substantial despite other treatments. And there's this paradox where after the first episode, people are at the highest risk for suicide, but clozapine is delayed and the antipsychotic and the anti-suicide benefits are often delayed until later on. I work in a hospital system, and the main message I tell our consult liaison psychiatrists is after someone with schizoaffective disorder or schizophrenia comes in with a suicide attempt, the response is to not put them back on whatever medication they were taking. It's to think about clozapine in that setting. So we really have to think about it from a systems landscape. And then finally, we're going to be hearing more about the Revisit C trial that Dr. Kelly is a part of, and others that are looking at the benefit of clozapine for people with aggressive behavior. And this really is probably about improving impulsivity rather than some sort of amelioration of positive symptoms. Okay, guideline to recommend. This is the recently published Integrate guidelines. And I just sort of put like a high level summary of where things fit in with the Integrate guidelines. LAIs are recommended really very early on. And then after that, 2 antipsychotic trials, ineffective clozapine trial. You could argue for 1, I think, in many cases. One of the questions that really sort of got me into this world was what happens when people don't respond to clozapine, or what happens when they might respond a little bit, which is why we call the clinic P-STAR, because it's actually trying to look at some persistent symptoms despite being on clozapine. And early on, it was sort of a psychopharmacology clinic while we were getting more people on clozapine, but it became an opportunity to really expand the psychosocial interventions. So we, over time have incorporated CBT for psychosis, ACT work, supported employment. And I think that the future is kind of like maybe for clozapine, something like coordinated specialty care for early psychosis. It really is this sort of coordinated model with all of the right pieces around, and the pieces talk to each other and coordinate the care. Because really, as wonderful as clozapine can be, for some people, additional psychosocial interventions or additional medication options are needed. And getting back to the Integrate guidelines, for refractory positive symptoms, they talk about using aripiprazole, amisulpride, which isn't currently available in the US, but there's some efforts to do this, or ECT. We can talk more about persistent symptoms despite being on clozapine in the Q&A. Don't have to really tell you about the efficacy. This is a key point, is the early initiation of clozapine. There's been study after study that's shown that the longer the delay, once the so-called diagnosis of TRS is made, the less likely one is to respond to clozapine. And in this study rate, after clozapine initiation, and then after 2.8 years, it was 31%. But there's also other studies which suggest that later on, that when you start clozapine later on, it can still be quite effective. So I don't want anybody to think that, you know, if you miss the early window, it's over. I think people can still do quite well. We just don't want to be getting into antipsychotic 5, 6, 7, 8, 9, because this is what I see all the time. We did a survey one time of prescribers across the country and prescribers where I live in Georgia, and really it was sort of a survey about clozapine. So I think people probably knew where we were going with this, but the majority of the respondents actually preferred to use 2 antipsychotics together in comparison to using clozapine. For a person who had, hadn't had success with 2 antipsychotics. I was surprised. I thought that was going to be like a softball on the survey question, but I guess that's not where we were at the time. Clozapine and suicide. I think the key point here is, from a system standpoint, we've got to do better at identifying people who have suicidal thoughts and then being able to offer them clozapine. In one study in the VA of people that were eligible for clozapine, only 1.1% of them were actually on clozapine. Well, we can actually use the PHQ-9, question number 9, the suicidal ideation question, and then look at the diagnostic code, and then kind of say, okay, maybe these are people that could benefit from clozapine, and then proactively approach clinicians about that. Okay, now moving on to clozapine and safety and monitoring. So we asked our patients one time what were the side effects that they experienced most commonly, and drooling was number 1, over 70%. Low white blood cell count was the least reported side effect, and this is the one that we spend the most time talking about. So many of you were involved with an incredible advocacy win at the FDA, where we together were able to eliminate the REMS monitoring. And that has been probably the biggest sort of thing I've ever been a part of in my career. The thing I'm probably most proud of is that day at the FDA, where many of you also testified, and we were successful against the FDA listened, and now we no longer have the REMS. And a lot of it, I think maybe down the line, the utilization of clozapine will change, and I think that was a first key step. But I just want to talk a little bit about neutropenia. And the key issue with neutropenia is that it's probably the number 3 or 4 like kind of highest reason for mortality for people that are exposed to clozapine. Is definitely not number 1. That's probably pneumonia, complications from ileus, and then possibly myocarditis. So neutropenia is a serious problem. The monitoring is really important, specifically early in a clozapine initiation. Point of care testing can play a really important role in helping to improve access during those first 18 weeks when the risk is the highest. I'm a huge proponent of point of care monitoring, and I think that you never want the perfect to be the enemy of the good. But early in a clozapine titration, it's very important to also consider looking at myocarditis labs. We do therapeutic drug monitoring, and sometimes, just by using the finger stick, you can't get access to all of that information. You just get the ANC. So I think that a combination of phlebotomy and the point of care test is really what's needed to most safely initiate clozapine these days. This is a little bit about the timeline of how everybody worked together to ultimately remove the REMS. It's been over a year now. And I just want to thank everybody in the room for their advocacy in making this change happen. I think that some of the potential risks that Dr. Nasrallah alluded to a little bit was this idea of if you're, because the monitoring provides a touch point for clinicians to be able to see their patients on a weekly basis. You get to know people really well when you see them on a weekly basis, even on a monthly basis. And I think some people think that one of clozapine's benefits is sort of intertwined in the monitoring and sort of the frequency of clinician visits. I guess I would argue that in randomized controlled double-blind studies, everybody's meeting with the clinician an equal amount of times. So I don't know how much of it is that, and I don't necessarily 100% believe that meeting with the clinician more often is sort of improving care. Sometimes clinicians, myself included, the more you're meeting with someone, the more stuff that's done, the more intervention that's done. Sort of, you got to really right size that. But I do think that even though the monitoring now is no longer governed by the REMS, we have to think about what's the best frequency of visits with the clinician and make sure that there's other things that connect patients to the system. Maybe that's psychotherapy, all of the other things, and it doesn't need to be connected to the hematologic monitoring. This is the FDA Great Room where it all happened. And here are some of the proposed alternatives, which many of you are aware of. On the upper corner there are the Delphi guidelines, and then in the lower right side are the guidelines from the Clozapine European Task Force. In the health system where I work at, we've implemented the Delphi guidelines, which I'll talk about in a moment. So the top bar is the Clozapine United States package insert, weekly monitoring for the first 26 weeks, every other week for 26 weeks to 1 year, and then monthly ad infinitum. The Delphi guidelines really a departure from that and suggest weekly monitoring for the first 18 weeks. And from my perspective, the weekly monitoring is really essential during those first 18 weeks. This week, actually, Amit Sarpatwari and colleagues just published a study looking at kind of adherence to hematologic monitoring over a long period of time. And they found that really it's not very good, that even before the REMS, we didn't do a very good job of being compliant with weekly monitoring. So an important consideration when you talk to your clinicians is to not have them create kind of a separate REMS on the, kind of a proxy for a REMS. I would really encourage us to kind of have discussions with our people that we work with. And we don't need, at least in my view, a system to create another version of the REMS, which can be dangerous because those can be different in different places. And they can ultimately result in, my fear is, people not being continued on clozapine. I think clinicians have to document something like this. This is from John Kane and Jose Rubio. Jonathan Meyer and Jose Rubio, kind of give some guidelines for what to document in the record if you diverge from the United States package insert around hematologic monitoring. So if you are talking with a prescriber and they're hesitant, you can say that there's actually templated language out there that you can incorporate into your notes that might help to make this easy, more palatable. Another key point here is that the United States package insert says all kinds of things that probably could be changed and need improvement. And the United States package insert is not really, there's been some legal cases about this, but it's not even admissible in many courts. And the standard of care is not defined necessarily by the package insert. All right. So, everybody is sort of in a different place, with clozapine and a journey around that. A really important place is how clozapine is started. And I increasingly believe that a slow titration is essential to clozapine success. Thanks. That it's part of the ease method. The slow titration is really, really important. And the reason for the slow titration are multifactorial. I mean, first of all, just from an intuitive standpoint, if you titrate a medication rapidly, people are more likely to experience side effects and sedation, orthostasis, and say like, whoa, this is like way too much. I don't want to do it. I don't want to do it again in the future. A lot of times you got sort of one chance with the clozapine titration, and you have to take that very seriously. At least I do as a prescriber. So another reason is that a slow titration is more likely to, is less likely to cause myocarditis. Faster titration is more likely to cause myocarditis. And probably neutropenia. I really worry about people that are started on clozapine and sodium valproate simultaneously. So if you have a person that's getting started on clozapine and they're on Depakote, question mark. Okay? There's more likely risk for neutropenia, more likely risk for myocarditis. Yes. People who are started on clozapine and Depakote together have a greater risk of neutropenia and myocarditis than those who are not on Depakote. The other problem that we get into sometimes is the use of the myocarditis screening protocols themselves. I think that it is a good thing that overall, like clinicians are thinking about myocarditis, it's on the radar. And people will often monitor CRP and troponin on a weekly basis. And sometimes they may see fluctuations in the CRP and fluctuations in the troponin and say, okay, we're worried about myocarditis. But it's important to know that there are specific consensus guidelines around when do you stop based on the CRP and the troponin. And I see a lot of people getting stopped too early because of the myocarditis protocol, and then they're hesitant to be back on clozapine. So on one hand, it's a real positive that we are using these screening protocols, but on the other hand, there's some unanticipated consequences about people being stopped on clozapine too early. And I would refer them to this guideline that Elias Wagner and others were a part of in the British Journal of Psychiatry. The other thing to know about this is that infection increases clozapine levels. Okay, so if somebody has an episode of, pneumonia, for example, and they need to be in the hospital, I really encourage people to check a clozapine level at that time, because what happens with infection is it pretty much stops the enzymes that metabolize clozapine from working as effectively, and it drives up the levels of clozapine in the body. And then people get not only an infection, but they have symptoms of clozapine toxicity. And then, when you go to the hospital, everything is blamed on clozapine all the time. Okay, so infection, definitely you want to get a level, and you want to advocate for a level, and you want to, maybe even consider holding the clozapine. We learned a lot about this during COVID. Antipsychotic induced weight gain, specifically with clozapine, which has been a big topic already. Here are some new guidelines that came out around prevention of antipsychotic-induced weight gain. On the clozapine side, the key takeaway, what I think about a lot is like if somebody's on clozapine, we co-commence metformin just right out of the gates. It's sort of a package deal, clozapine and metformin, package deal, and then we stop the Depakote. I don't know how many times I've said that. Clozapine, metformin, stop the Depakote, slow titration. You can also see where the guidelines are for other medications, but what I like about this is the much earlier use of the GLP-1 receptor agonists for people, and this is on-label GLP-1 receptor agonist use, like BMI greater than 30 or BMI 27 to 30 with these sort of comorbidities. And there's definitely issues with the BMI. There's just even how it's calculated, but I think it's a good, it's a starting place. It's sort of a, it's much easier to have a discussion with the insurance company when you're using GLP-1s for the on-label indications. And we've been using GLP-1 receptor agonists since 2017, back with the liraglutide study, which was a daily GLP-1 receptor agonist, and it's not nearly as effective as tirzepatide or semaglutide. Oh, I would say before we move on, it's very important to make sure that people are continuing to have regular bowel movements when they're on clozapine and when they're on a GLP-1 receptor agonist. Entire colonic transit time gets slowed down. We'll talk more about preventing ileus. Okay, so the big things that keep me up at night are worrying about the risk of sort of complications from constipation and then also pneumonia. These are some of the biggest risks of clozapine. And this was again shown in a large Finnish registry study. We put together like a little kind of some sort of a graphic on how to reduce complications of pneumonia. And I think it really starts with prevention. That's making sure people are up to date with their vaccination schedule, weight loss, and smoking cessation. The reason that clozapine causes pneumonia is probably many reasons. It may have some to do with drooling and then people aspirating. So in the past, before a lot of this literature came out, if somebody had some drooling and it wasn't really that bothersome, I would probably say, don't worry. Like if it's bothering you, then yes, let's do something about it. But if it's not bothering you, okay. But now I would probably say, okay, let's minimize the aspiration risk and probably more aggressively treat the drooling. Okay, clozapine levels. I think this is really one of the best ways to manage clozapine safely and effectively. And the Delphi consensus guidelines that came out about the neutropenia monitoring also had a section about how often to do therapeutic drug monitoring or just getting a level. Antipsychotic levels are available for all antipsychotics, not just clozapine. They're just not widely used, and it's kind of hard to understand why, because they really give you a lot of information. And one helpful bit of information is somebody taking the medication or not. Is the medication level too high? Is the medication lower than you would expect? Is there something about somebody's physiology that's, breaking the medication down too fast or breaking it down too slow? So clozapine levels are essential in helping to understand that. We usually get clozapine levels after about someone's on 100 milligrams of clozapine or so, or even earlier sometimes. And then if there's any change in a smoking pattern, if there's infection, change in mental status, any other medications are added, then we're getting also clozapine levels. One thing that we did in our system was we got a rapid response clozapine test, which comes back at the same time that the other blood work comes back at using an immunoassay, which has been a real game changer. So somebody comes into the hospital, they're not doing great. The first thing we do is we get a clozapine level, see if it's too high, too low, it comes back. It's not a send out test. It takes 4 or 5 days to come back. If you don't know what one's own clozapine level is or a loved one's clozapine level is, you should probably know. And just so you know, you get a clozapine level and you get a norclozapine level. The thing that's most correlated to its efficacy is the clozapine level itself. The norclozapine level, probably less important in that conversation. Management of sialorrhea. This is a really bothersome and problematic side effect. And the key is to not do cogentin, is to avoid cogentin as much as possible and use topical treatments like atropine or ipratropium bromide. I think another promising intervention is Botox injections. It's very difficult to find an ENT specialist or neurologist to do Botox injections, but they're extremely effective. And you can use Botox in the parotid or submandibular glands and really help to improve the sialorrhea for a few months. Sort of at the end of the road, really after all these other options have failed, then we sometimes can consider glycopyrrolate. It's an anticholinergic medication. The problem with glycopyrrolate is that it can also contribute to slower gut and people not pooping as regularly. It does not cross the blood-brain barrier, which is one advantage of it, so people don't get the cognitive anticholinergic problems. But we really try to avoid using glycopyrrolate. And then totally avoid using benztropine or cogentin. So we created some time ago some videos for how to actually administer the atropine drops or the ipratropium spray. And this was back when I was working with SMI Advisor. These videos are still up on YouTube. This is actually in my office, believe it or not, like that setting. We shoot a lot of movies in Atlanta, and like it was easy to kind of convert my office into like a movie set. And I kind of got into it with the director around how we're going to do the shot. I'm staying out of it from now on. But there were some really helpful videos. We got some consensus around what's the best way to actually administer these drops, because the way that you do it matters. Because a lot of people will say, oh yeah, I took the atropine, it didn't work. And then if you ask more carefully, it may be because the technique wasn't quite right. This is important on inpatient units and outpatient settings. Okay, so here's just a framework about kind of what labs to get when starting clozapine. The only one I want to point out that's maybe a little different is screening for interstitial nephritis, which is sort of an immune-mediated condition. And we typically get weekly kidney function until week 8. Slow titration, very important. And you could probably get away with it a little bit faster on the inpatient unit, hospital a little bit longer. And I think that's not a popular thing with the administration folks, but it's necessary. And then in the outpatient setting, we go a little bit slower. This is a resource on SMI CalAdvisor that we created, a clozapine titration planner, which goes through a couple different variables about ancestry and dosing, and you kind of put the date in, and then you kind of show what the titration would look like. Clozapine should be dosed at bedtime. This is, even though it's a California resource, it's available for everybody. The website is SMI CalAdvisor. All right. I don't know if I'm going to be able to move to that side of the room and talk much about Cobenfy. I apologize. I've got about 5 minutes, but what I really want to talk about is how do we get more people on clozapine? How do we change our system in order to do this better? And there's a couple ways. This is it's a very difficult problem. I think that the end of the REMS was a real positive, but there's many other issues. One of them is a clozapine clinic. And there's benefits to clozapine clinics. There's many benefits. But one problem with the clozapine clinic, like I run a clozapine clinic, and then what happens is people outside the clozapine clinic, they have De-skilling, you hear that in the AI age, you know, there's a de-skilling because I'm using AI, but there's a de-skilling of using clozapine, and then people don't want to use clozapine and everything has to go back to the clozapine clinic. So in some ways it actually can reduce access. But in places where there's really not a lot of clozapine used at all, having clozapine clinics can be a real help. The problem is we're always fighting like capacity, and you know, somebody then comes from the hospital and you know, we get, somebody lets us know, oh yeah, this person's being discharged, they need to be seen tomorrow in the clozapine clinic. And then we need to figure out how to be able to see them on a weekly basis moving forward. And it's very difficult to sort of build a system with that sort of flexibility involved. And we just have to move away from a fee-for-service reimbursement. I've really been focused on this education piece. So I work with the residents at Emory. When they come in, I tell them, look, you're going to become an expert on clozapine by the time you leave here. And some of them are like, that's not really what I was hoping for, but that's really like everybody works in the clozapine clinic. There's a lot of education around clozapine. And then I'm trying to make an addition. I want them to commit to something else. After they leave, they need to continue to prescribe it, because sometimes that doesn't happen. There's a lot of things that we need to do on the policy side. And I've been talking with some of you all about ways that we can do this through incentives and through disincentives to really make sure that there's a financial model in place for clozapine. It takes longer. It's a labor of love a little bit. There's some extra stuff you got to do, but it's obviously worth it. And then finally, every state should have something like what Deanna Kelly set up with the ECHO model, kind of a spoke hub model. I really hope that more states adopt this. And I wish she was here to be able to talk more about it, but I think that things like this are the ways in which, you know, we sort of develop central champions, and then we have sort of kind of a consultation model throughout states. So the big thing with Cobenfy is, you know, I really believe that whatever schizophrenia is actually multiple different things, that we just haven't exactly figured out what it is. And for many people, the main problem with positive symptoms is an excess in dopamine, presynaptic dopamine in the associative striatum. So it's kind of here what Kesh was talking about. What Cobenfy ends up doing is it modulates some of that presynaptic dopamine release in the associative striatum. So you essentially, even though it's a muscarinic agonist, it's affecting dopamine downstream, and you're getting less of that dopamine in the area that contributes to the positive symptoms. And this is a complicated slide that basically explains that. Earlier on, we started to figure out that muscarinic agonism had some effect for people with psychosis from some of the work that was done with people with Alzheimer's that had psychosis. But really the tolerability of these muscarinic agonists was problematic. And then I think the real innovation was when xanomeline was combined with trospium, which helped to counteract some of the peripheral effects of xanomeline. So it's basically a cholinergic agonist in the brain, and then there's cholinergic agonist and antagonist in the periphery, and those together kind of cancel out the peripheral side effects. So Cobenfy right now is generally started twice a day, and it's with food. This is a little bit about the titration. And the key thing with the titration, I think, at least from my experience with this, is to go slow with it. And sometimes, this is what it says in the package insert, I like to go even slower than 50-20, particularly when it's not an extremely emergent situation. Here are some of the studies that have been done about Cobenfy, some of the phase 3 studies, short-term and long-term data. The important thing about Cobenfy is the side effect profile looks different than the dopamine receptor blocking agents. It's not associated with weight gain as much, the motor side effects. And there may be some cognition signal, particularly for people who have rather impaired cognition sort of to start with. But I think more work needs to be done on that. What I found really positive was that there's been some qualitative studies that have been done from the phase 3 data in which people who have been on Cobenfy actually talk about their experience and the quality of life, which has been a really nice, I think, approach. And people have found improvements in positive symptoms, improvements in daily functioning. I'm really glad that they built this in. This is a study called the ARISE study that looked at Cobenfy plus an antipsychotic plus Cobenfy, because there's been questions around if you add another, is Cobenfy really going to be a monotherapy, or are you going to use one antipsychotic and then add Cobenfy? And it turns out from the ARISE study so far, at least the preliminary data that's been published, is that when you add another, really when you add Cobenfy to another antipsychotic, you don't get a lot of additional benefit. So it's really probably going to be used more in a monotherapy sense. But we need, to sort of fully understand the story. It has not been studied for people who have failed 2 antipsychotics yet. But mechanistically, I'm unsure if it's really going to help in the same way that Clozapine is going to help. This is some switch data that was published at the CURESZ meeting. And people were, it was about if you're on an antipsychotic and you're trying to get to Cobenfy, what's the best way to do that? And they looked at 4 weeks, over 4 weeks, or over 2 weeks, and they found that outcomes were about the same. To me, switching somebody to Cobenfy over 2 weeks is pretty fast. I've typically gone 6 to 8 weeks generally when I do this, but really this was sort of a tolerable approach. Availability often requires a prior authorization. We talked about the potential role for TRS, and it's quite unclear. I do think that early when Cobenfy came out, a lot of my colleagues were talking about using Clozapine and Cobenfy together. And, part of the challenge with that is that norclozapine actually has a lot of muscarinic agonism properties that kind of overlap with what Cobenfy is already doing. So to me, it's a little bit mechanistically unclear if it's going to work. And then I really worry about it slowing down the GI tract even further, leading to complications of constipation and ileus. We had a colleague, John Leung, who just published a case series looking at Clozapine plus Cobenfy, and he found that there wasn't a significant improvement for people that added Cobenfy at the time. We don't know how Cobenfy is going to do for TRS alone, but I think the big advantage for Cobenfy is that for people who are responding to a dopamine receptor blocking agent, and they're having side effects, particularly extrapyramidal side effects or weight gain, Cobenfy could be a really nice option if they respond. So there's also studies going on for Cobenfy in early psychosis that are very promising. And I think that for somebody with the first episode, Cobenfy could be a really interesting choice. It may be difficult to get it approved through one's insurance company without other, step therapy kind of things, which kind of defeats the purpose. But and another big question about Cobenfy is, what does the data look like for bipolar depression? What does the data look like for mania? All of those things are still kind of yet to be determined. But I think this is a really, really promising compound, and we need everything we can get. We need Cobenfy, we need Clozapine, we need to figure out where Cobenfy is going to go in our treatment algorithms. And the big key is that it does not delay effective Clozapine use. Thank you for the additional time. Thanks, everybody.
Bethany, in addition to publishing that first book, her memoir, she also published a book with me last year called Awakenings. And she's also a motivational speaker. She gets invited all over the country to inspire families and mental health professionals. And I really think she's doing a great job in that regard. And this activity is another example of what she can do. I think I'll stop at this point, give you the time, Bethany, to go ahead with the next program.
I have one. I should have this one. All right, it's such a pleasure to be in front of you today. I know your lunch is in half an hour, so we'll make sure to hurry up. And I'm not just presenting myself today. You may have seen in the program, Sarah Marzen. Sarah, why don't you stand up just briefly? I'll just say in a few words, Sarah Marzen inspires me. She is a tenured physics PhD, a professor at Claremont McKenna. Beautiful example of what is possible. Now, Dr. Nasrallah told you already today, when I was picked up by police from the churchyard where I was sleeping as a homeless person, I was taken to a hospital, and the doctors told my parents within less than 48 hours before I had ever started an antipsychotic, Bethany is permanently and totally disabled. No school, no independent living, no work. She is basically just done. Fortunately, that didn't happen. But when I look back at USC, what really strikes me is the lack of education. I think many people in the general population, previously myself included, really feel that schizophrenia is behavioral. It is a choice. You know, when I was growing, I thought people with schizophrenia, they need to just be strong. They need to pull themselves up by their bootstraps and just get over it, just act normal. I didn't know that I was dealing with a brain disorder. I think antipsychotics are miraculous. You take a pill, and then for me, you go from wanting to be homeless, sleeping outside, hallucinating and seeing things, and all of a sudden, you're a productive member of society again. I mean, even for me, oftentimes I look in the mirror in the morning, and it's like, how is this possible? How could I have been this other person, this street person? So I'm going to talk to you today a little bit about my story, which many of you know, and we're going to really focus on CURESZ Clubs. And I think I'm going to move over just a little bit here. So I am a recovered bear cat, as many of you know. I started out as a Trojan in 1999, where I was doing research and playing violin in the community orchestra. Things were going very well. But graduation and a PhD program didn't happen. Instead, I became homeless for 4 years to the day. And then I met Dr. Nasrallah in 2008. You know, my first 3 antipsychiatrists they thought I was just totally disabled. They thought we were done. And Dr. Nasrallah, he was so different. He researched me. He knew about my success at USC. He knew about me playing violin as concertmaster in the orchestra. I would just say right out, research your patients. Find out about their passions, their accomplishments. It's pretty easy now with the internet. Can make all the improvement in the world. It can make a huge, huge difference. And yes, Dr. Nasrallah's next idea for me after I graduated was, why don't you write a memoir? And so I ended up publishing Mind Estranged at that time. Prodrome, I guess I'm speaking to the choir here. Prodrome, Dr. Nasrallah said it was a year before the first clinical episode. For me, it took a little bit longer than that. I remember I'm at USC, and I'm not interested in speaking with my parents anymore. And then I was in the lab all the time, and I ended up dropping out of the lab, dropping out of the orchestra. My grades were slipping. No idea that I was dealing with a mental illness. I love this picture. My mom was so proud. And that's me in the lab. I was talking to Sarah last night about the research I did at USC. We were working on something called a DNA polymerase that replicates DNA and makes mistakes. And you would see analogs in human cancers. I was going to cure cancer. I was going to find a treatment for HIV. I was going to do so many wonderful things. I was so excited about my life. You know, it's interesting, though, looking back, looking at my prodrome, because for a while when I was in that lab, I will say the professor had won $2 million, and he was doing really well. But for a while, for me, I started to think, is he going to win a Nobel Prize? Can I be part of a project that's going to win a Nobel Prize? Now, this was a great scientist. This wasn't happening. So this was one of my very first delusions. It came on very, very slowly. And then I ended up going to Africa. And when I was in Africa, I started believing that I would raise billions of dollars for people living in poverty overseas. And as many of you know, this is what happened to me instead of becoming a PhD researcher. This is the dirty, homeless stranger I became in the USC area. And again, it went on for 4 years. There's about a 3-year period where I was hiding in libraries and lounges. And then that 4th year, the hallucinations started. They started one single day. I still remember January 28th, 2006. All of a sudden, I hear this chorus of voices in my mind. And then I think to myself, am I mentally ill? Do I have schizophrenia? And then I think, not a chance. I am way too smart to have schizophrenia. I'm way too strong to have schizophrenia. That's just not possible. You know, I'm just looking back. What if I had been in a CURESZ club when I started USC? What if I had been told that schizophrenia, bipolar anxiety, depression are in fact disorders of the brain? You know, what if I had been told in a CURESZ club, you know, if you're losing interest in activities you used to love, your grades are dropping, you're quitting your job, you know, something deeper might be going on. And, you know, you need to see someone. There is hope. There should be no hesitation to see a doctor, a counselor, or even to just talk with a friend. So it's one of the main reasons we ended up founding our Cures on Campus clubs. And yeah, I will say, I was just a statistic living in LA. At that time, I thought I'm going to be a billionaire. I'm just waiting for God. I'm sleeping in the churchyard every night. Many of you know, I thought that a helicopter would come right one night and pick me up. One night, actually, when I was in the churchyard, I saw George W. Bush. He was as real as any of you look to me right now. And you know, it is amazing looking back and thinking, I just had not a clue of insight when things were going so badly. So I was picked up on March 3rd. A little off topic for this lecture, but I am a big, big fan of involuntary hospitalization. I don't think I would have asked for help for my schizophrenia in a million years, not a chance. I felt like society was a pyramid and people like Dr. Nasrallah and Dr. Keshavan were at the top, you know, and then maybe people who made 50,000 a year. And then at the bottom of the pyramid, there was people, you know, living on the government and unable to work. And there's also so much stigma attached to schizophrenia. You know, these things I was thinking. They're not accurate, they're not kind, but I was just completely ignorant of what it means to have schizophrenia. I remember the doctor said, "We're starting you on risperidone." And I said, "That's what you think. You're not starting me on risperidone." It worked so well. Now, the voices were still breaking through and I had side effects, but it did work very well. But I went off it anyway. And that led to my next psychotic episode. And I am very grateful that I developed my insight during that second hospitalization. I would stay on medication. That was 19 years ago. And thanks to a wonderful conversation with a kind, listening doctor who explained how dangerous it is to go off antipsychotics, going off them and on them again. Because of him, today I'm here talking to you. My parents, who are both here, by the way, at the table, were unbelievably helpful, would never give up. That's Dr. Nasrallah. That's my graduation, which again, it was supposed to never, ever happen. So Cures on Campus Clubs, this is Lizzie Kozarek. She was our first UC club leader. Very smart, committed girl. She wanted to be a psychologist and work with low-income kids. These are some of our Cures Club members today. We have Jack, Abby, Kira, Ina, and Nanal. We also have a program I'm really proud of that we're calling Cures Ambassadors. We're training people to go around the community and speak publicly about schizophrenia. And I don't mean to embarrass anyone, but Leaf, are you here? Leaf is one of our schizophrenia ambassadors. So he's been, Yeah, Leif has been giving presentations. He's been wandering around the Alberta community, sharing our books, sharing the CURESZ Foundation. So we're very proud of him. Jack and Kira are undergrads. Abby's in a PsyD program. Ina is in a nursing program, and Nal is pre-med. These students are amazing to work with. I talk with them very regularly. I greatly enjoy it. But I don't want to just open these clubs up to people who are pre-med and nursing. I want the architects, I want the engineers, I want the artists. I want everybody to be able to come together, have fun, get to know each other, have a safe space. And I want all these people to be educated about what it means to have schizophrenia so they won't think what I was thinking. And that there today really are treatments, there is hope. We have a virtual lecture series. We open these up to all our subscribers. We haven't set in stone our meetings for the fall semester, but we will in the next month. Please join us. This is actually a lecture by Christopher Merritt. If you see the slide there, he's a forensic psychiatrist. Our students loved hearing his journey through undergraduate medical school, residency, fellowship, and a lot of what he does day to day. So lots to share. We've talked about this a lot today, Dr. Nasrallah. This is something that is so important for our students. I really like this slide. And again, Dr. Nasrallah had similar slides. For every psychotic episode, more brain damage is done. I wish on the day I was diagnosed, somebody had shown me a slide like this and said, every time you go off this medication, there's going to be more brain damage. This is not a choice you're making to act normal or not act normal. Again, this does not mean you're weak. This is an illness. This is treatable. Another thing, cannabis. We need to educate our young people about how very, very dangerous cannabis can be. You are the leaders in our society. You are passionate. Take the time to talk to young people. Because as you know, for some people, cannabis, it's like a light switch. Turns on, and sometimes you can just never turn it off. Quick story, a family contacted me through CURESZ. The girl was using marijuana gummies. Got off them, got on Clozapine, full recovery, done, no problem. She goes back to her doctor and says, hey, I want to use gummies again. What do you think? Oh, fine, safe enough. Okay, so she goes back into psychosis. She goes on Clozapine again. Clozapine doesn't work anymore. So anyway, I don't know how she's doing. I lost track of her. But you know, I hate to see this in promising young people. So educate our young people. Let's work together and tell them about cannabis. And this is my last slide. This is our Cures on Campus Club at UC winning the Inclusive Excellence Award. This is Minahil and Kemi. Minahil is about to start medical school. Kemi, last I talked to her, was going to become a physician's assistant. They actually won this award for their mental health break nights. Our clubs have come together to do bingo. They've done pumpkin painting and jewelry making. They always have fun things they're coming up with. And I just love partnering this social support with the education they're offering them. So anyway, this is a little bit about CURESZ Clubs. If anybody has friend, relative, colleague who'd like to start a club or to become a CURESZ ambassador, please do talk to me. I would like that. And at this point, I'm going to welcome up Sarah, and she's going to tell us a little bit about her journey to becoming a tenured physics professor and also CURESZ Clubs.
Hi, my name is Sarah Marzen. I am a physics professor, and I'm just going to tell you about a story of, it's not recovery, it's more management. Like today, last night, Sarah Cole didn't really work. I got really bad sleep. You may have noticed that I wasn't here for a little bit. I had to go back up to my room and rest because I was seeing double. I was talking to myself. I had voice interjections in the morning. Like I thought my thoughts were being intruded by like an alien voice. So there's a lot going on all the time, and it's not always good. But I'm going to tell you a story about how you can manage to succeed anyway. And I'm going to tell you a little bit about where I think CURESZ Club's going to fit in. So really, this is a story of privilege and suffering. And I want to put that in because even though There was intense suffering. There was a ton
That's
of
David.
privilege in my life. And I started out in a what I call broken but gilded home, and I'll show you a picture of the house. And I performed really, really well, but I was really, really sad, and my brain sort of was breaking a little bit. Then my brain completely broke with a sexual harassment case in graduate school. And I finally figured out, because I took the right medication, that I had a biological problem. And I had insight, but then I had depression. So I started taking medication. And finally, with medicine and social support, I was able to become a tenured faculty member. So this is a picture of where I grew up. As you can tell, it's a really nice house. It's in the suburbs of Washington, D.C. I think the home is worth like $4 million. And my parents were so rich, they were both lawyers, that my mom worked at the Treasury Department and earned maybe 100K a year. And my dad was earning so much more than her that he told her that what she was doing was a pittance and that she should just quit. And so she quit and she took care of us instead. And this was a double-edged sword, because even though she was wonderful and she was sort of coaching us to be better and better, she also demanded really, really high performance from us. So, for example, when I was in 11th grade, she really wanted me to excel. 11th grade is the year that you want everybody to excel because they're about to apply for college. She sat me down with an Excel spreadsheet, and she wrote in an Excel spreadsheet of, these are the grades you have to get. These are the scores you have to get on all the competitions. These are the awards that you have to win. These are the people you have to impress. I didn't have any symptoms at that time of anything. I just looked at the Excel spreadsheet and I said, oh, okay. So she was a tiger mom. She happens to be both Jewish and Asian, which maybe kind of explains it. So I just said, okay. But that year, I actually failed to achieve some of the goals that she had set out for me. And she was so disappointed, and I felt so guilty. I was suicidal for the first time in my life, and my brain started to sort of slowly break a little bit. But I got myself together and I said, okay, my parents don't want to pay for college because I got a B+ in AP Chem. Like literally, that's what it boiled down to. And they made it clear they didn't want to pay for anything. They thought I was going to be frivolous with the money. As a result, I had to get my own merit scholarship, so I got a full ride to Caltech. I worked really hard, and basically, the story throughout here is I achieved really well, and I achieved more and more and more. But I was broken on the inside, and I was really sad, and I was still upset that I disappointed my mom. So, for example, here's something I achieved that I will always be very proud of. In 12th grade, I was selected as one of the top students in the country for a physics test called the Physics Olympiad. If you do well in this test, it guarantees you a job in a good finance firm, basically, because it means you're so quick at math. I was the best non-traveling theorist, which meant I was like the number 7 person on in the United States on physics. That was high school. I then went to Caltech on that full merit scholarship, which paid for everything plus a little bit. And I got merit awards while I was there, and I got my BS in physics. I wasn't showing signs that I was about to crack. Everything seemed okay. I just was sort of sad and broken. And then I got my PhD from UC Berkeley in physics, and it was during my graduate school years that I really started to crack. So I worked at the Redwood Center for Theoretical Neuroscience. It was sad that I was the only girl there, literally the only girl, because it was about artificial intelligence, and it was very closely related to theoretical neuroscience. If you know how intertwined these two fields are, the way they do it there. There was a man that had harassed me a little bit. He was my friend, and then he harassed me. I didn't want to bother. I left the center. I just didn't show up to work. I was still doing work from home, but I didn't show up to work. I didn't say anything for a year, and then 3 women came to me and said, so you're the only woman here. Why did he sexually harass us? And I said, this is a problem. So we talked a little bit. And then we went to the faculty and we said some stuff about him. And the stress of it all broke my brain completely. I felt guilty because he had been my friend. I felt like we had done the wrong thing. And it was really, really, really hard for me to deal with everything. And this is when it really started to happen. Okay, so you may recognize this movie, A Beautiful Mind. And I think that some of the scenes where John Nash feels like the CIA is following him really mirrored my life. I thought I was being followed everywhere. I was living in San Francisco with my boyfriend at the time, and I would go to a cafe to see my friend, or I would go to a diner with my boyfriend, or even to a remote location in San Francisco because I thought people were listening and we needed to get away from all the bugs in our house. And I would see the same man walking by or sitting there, and we're holding a newspaper upside down, some sort of PI watching me. And I freaked out. And eventually, the Harvard Business Review published a post that made me think that there had been a fake email related to the sexual harassment case. And I thought there was a secretive magical organization that was controlling the entire world, that was controlling my image, that was ruining me. And I said, I have to go home and marshal resources. I don't know what I'm up against. My parents have enough money. We're going to fight this in court because they got the date wrong. It was a really complicated story that basically sounds like Harry Potter if I tell it to you. So I went home and I marshaled resources. And I didn't get anywhere with marshaling the resources. There was nothing to marshal against as far as anybody could tell. But they put me in 2 psych wards because they couldn't figure out what to do. So here I was, seemingly incredibly successful. And I seemed to be kind of with it, but then whenever I talked about this stuff, I seemed completely out of it. So they put me on antipsychotic after antipsychotic, and nothing worked. And the most they could do was knock me out to the point that I just didn't care. So they basically did that, and they sent me home. And for years, so for the rest of graduate school and for the beginning of postdoc, I was completely out of it, talking to voices all the time, thinking they were people. Like literally, I thought I was talking to somebody in London. I would check my clock to see if this person were reasonably up because I thought I was maybe getting fooled by the voices, and that was the amount of lucidity that I had left. At the same time, this is my Google Scholar from that period. And I was publishing maybe like 10 papers a year, which is a lot. So, and I was like first author on a lot of them, and I was basically writing most of the papers. So somehow the scientific stuff was coming out beautifully. I was getting like awards for my science from graduate school. They never saw me in the office, but they didn't really care because the output was so good. I went to an independent fellowship at MIT, a really nice, prestigious thing, and you wouldn't be able to tell that anything was wrong, except I never came into the office. And when I did come into the office, I was really weird. I was like kissing doors. It didn't make any sense. Finally, I realized I was sick. So I had a relationship with a voice, and it was so overwhelming that I overdosed on clozapine. I was on clozapine. They even had a nurse come by and make sure that I took it every night. But I was very clever, and I hid the pills. I put them under my mouth, and I just took them out and put them in a safe place so that I could overdose later. This was not the first time I had overdosed. I had to take my start date at MIT a month later because I had overdosed on 98 pills, and I downed like a swig of bourbon right before I got there because I was too overwhelmed by the voices. I nearly died. All of my friends didn't know where I was because my boyfriend, who at the time was away in Germany, and he came back to a house that was empty, and nobody could figure out where I was. There are flyers of me up in San Francisco. I was just in some hospital. Anyway, I finally had a good psych ward stay, so I went to the psych ward and they put me on Latuda, and that worked better for me than clozapine because clozapine just didn't work. Latuda worked because it coalesced all the voices into one voice, and I thought the voices were people, and I thought I was talking to people. And as soon as it did that, I logically realized, because I was logical enough, that the voices couldn't be people, because you can't have multiple people coalesce into one person. So I finally had insight, and I became really, really depressed, but this is my medication regime now. And clearly the sleep meds need to be tampered with, but whatever. So while I was in that psych ward, I got an email from the Claremont colleges, also from Wellesley. Basically, I had applied for faculty jobs because even though I was completely sick and completely out of it, my record was just so good that I got an email from a University of Michigan professor being like, you should really apply for our job here. Nobody knew. So I got an email from the Claremont colleges. They were like, please come in for an interview. And I responded 2 weeks late, and I just said, I'm sick. I didn't tell them anything. I finally had insight. I was finally able to not be a complete basket case. The only thing they knew is that when I went to interview on campus as a finalist, I couldn't walk around because for some reason my foot hurt. The reason my foot hurt was I was in a bathtub in a really bad position for about 4 days before my sister found me about to die. And so I didn't tell them that. I didn't tell them anything about schizophrenia, and they gave me the job, and I hope they don't regret it. They must not, because they gave me tenure. And later on, what happened, I came out as an accident. So I had talked to Ellen Sachs because she was so sweet. Bethany and Ellen Sachs remind me of they seem like the same person to me because as soon as I told her that I was schizophrenic, she emailed me back and she said, greetings, stranger, greetings, fellow traveler. We got together for lunch and she told me, under no circumstances do you tell people that you have schizophrenia. You're not going to get tenure. So I unfortunately didn't listen to her advice. First of all, I had to get disability accommodation, so I had to tell HR. Second of all, I had this physics magazine interview me because they had heard good things about my research. I told them about a research project that was actually inspired by the Land of Voices, this Harry Potter world. And so as a result of this project, I described it, and they basically gave me an opportunity to lie or tell the truth. So they said, where did this project come from? And I could have just said, I'm studying opinion dynamics and belief formation because I'm interested in the formation of cults, and I'm interested in democracy and how it functions and stuff like that. But I actually told them the truth, and I said, I'm schizophrenic, and I got the idea from my psychosis. And they completely changed the opinion piece. They were going to write about how I made music. Instead, it was half about the science and half about the schizophrenia. I sent it around to the department. They put me on the Academic Minute by National Public Radio, so I came out. Everybody was super nice. And then it wasn't super nice. So it was fine until I went to the point where I was going to get tenure, hopefully. And Scripps HR made it very clear that they did not want me there. So students were super great about this. Pre-meds, they were in my classes all the time. And as soon as I said that I had a disability and they were welcome to ask me about it because I had to tell them about my disability accommodations, they came to me during the off hours and office hours and they were like, so what's going on? Can you tell me about your symptoms? I'm really curious. Maybe I'm going into psychiatry. It was really great. I told them everything. I had one student whose brother was schizophrenic. He wanted to know exactly how to manage everything. I think he would be great for a CURESZ Club. There's a ton of interest from students in what this disability was and all that stuff. They really want to educate themselves. People who had mental illnesses told me later they found my ability to hold down a job despite a disability to be very inspiring, which was, I think these are great things. And then Scripps HR was like, okay, these medical leaves are costing us too much money. We want you out. So they didn't put it in writing really well. They just said stuff that was completely against ADA policy in private meetings. I asked to record them. They refused. And then they said, here's a paper, please sign it. You sign away your rights to tenure before we even look at your tenure packet, but we'll give you an extra few years to find another job. And I said, I'm not signing that under any condition. It ended up turning around because the tenure packet was so strong that basically they just dropped it. They couldn't say anything. So now I'm a tenured professor, despite Scripps HR, and this is part of my lab. We were celebrating dinner papers and all that stuff at a really nice dinner. And what I just want to say is I started this talk telling you about some of my symptoms this morning. I'm telling you about some of the difficulties I faced. I think one thing I haven't mentioned enough is how much my privilege has helped me. My parents are well off, and they made sure that I was housed and clothed and fed and everything the entire time. Even though I was spending money like water, not so much, but like a little too much. Anyway, there's a lot of things that are going wrong in my life in terms of this mental health stuff. It's not recovery, it's management. But I can still do what I'm going to do, and I can still navigate the waters. I can still give this talk, and I can still get up in front of classes and teach. And it's really thanks to the help of a social support network and medications, and it's just I'm really happy about that. Oh, and personally, I haven't been so involved with the CURESZ Foundation before, but I will say I think meeting Bethany has been one of the best things I could do for myself. So I was asked to talk a little bit about what CURESZ Clubs would have meant to me. I think they would have meant a lot at the right time. My problem was that I was so convinced I did not have a disease that when my then boyfriend tried to tell me about schizophrenia, I read an incomplete description, not realizing that everybody's symptoms are different, and I threw Ellen Sachs's book across the room. Like I couldn't read it. I was convinced my delusions were real. I still kind of am, and I just couldn't buy anything. But as soon as I had insight, a CURESZ Club would have really helped. I needed all the social support that I could get. I was just dying. I was so depressed. I think there are a lot of people that I know that I've talked to who would love to lead a club like this. There are so many students who really want to be educated about all this stuff. And this is an example of one of those students. His brother has schizophrenia, and he just wanted to know as much as possible. And he would be perfect for leading a club like this. Anyway, the story has a happy ending. This is my husband. I can show you my ring. And thank you. We were recently married. And yeah, I'm a tenured professor. Everything is going well. We got this huge grant to basically put like AI on drones, which is not great, but it's a huge grant. It allows us to study AI. And I'm so happy, and I'm so happy to be here, and I'm so happy that you were listening to my story. And I find this all really inspiring, and I cannot believe how many lives CURESZ has touched.
All right, so this is an open question and answer. You'll notice Dr. Tandon again, he didn't make it, but I think our other three panelists will do a wonderful job. I have a list of questions here if there are no questions from the audience. Does anyone want to start? I don't mean, oh, Chelsea. Yeah, take it away.
Hi, I'm just wondering why do they call it psychotic? Like a psychotic episode? Is that why do they call it that for?
Anybody want to answer? Why do they call a psychotic episode a psychotic episode? Where does it come from?
She asked, why do they call a psychotic episode a psychotic episode? Like, why does it? Yes.
Psychotic kid. The origin of the term psychosis, you're asking?
Yeah.
Yeah, it was developed a long time ago, maybe even more than 100 years ago, and came from the psyche. Psyche means the self, the soul, and psychosis. So it is basically a disorder of the self, the mental self.
Okay.
It's a good question, though, because we talk about it all the time, and nobody asks, like, where did this come from? Except good curiosity. All right.
Next question. Chelsea, you want?
Several hands on this side.
Oh, are there really? Okay, gosh. We'll just go across the room.
Hi, I'm anxious, so just
Speak up a bit, Chelsea. Make sure it's working.
I'm a bit nervous. Hi, my name is Chelsea Cole. I have been diagnosed with a schizoaffective disorder, and I've been part of CURESZ for almost 4 years now. But those who know me, I graduated from I graduated with my master's degree in neural engineering. So a lot of the stuff about the brain really interests me. I learned it, I was very sick while I was learning about the brain, but I'm really interested. I had an idea that was kind of sparked by many of the different presentations today. And I was wondering, my quick idea is that I was wondering, there are such things as personal EEG monitors that you can put on your head and it will scan your brain. I'm wondering if there's any way that people could have them at their house. They would monitor how meds work, how the different neurotransmitters work throughout the brain, the different brain structures at home, and then it would send results to the results via email to your doctor, and especially if there's like a difference in the brain structures. Also, I would hope that it would help figure out which medications would work, kind of like the blood tests that people have that say like, oh, you should take this medication. So I'm wondering if
It's enough, Chelsea, that we can answer that. Thank you. Anybody?
Okay, gotcha. I think anything that we can do to think about personalized medicine and medication for individual patients is interesting. I don't know if there's been any work like that done specifically. I don't know if there's a correlation between EEG and.
Go ahead.
Yeah,
Go ahead, Brandon.
please. Yeah.
Thank you. Great question. That could be so transformative for people's trajectories of illness and healing. Personalized medicine is really important, as you said. There's a company that I've worked with in San Francisco, and it's called Orbit Neuro. They're developing exactly what you're describing, a home-based brain monitoring device that enables the development of what they call a digital twin of the brain. So in the sense that they'll be using the data they gather from many people living with mental health conditions to develop a personalized AI-driven model of each individual's brain and mind, so that they can then help treatment providers with personalized prescriptions and personalized treatment recommendations using that, quote, digital twin of your brain or mind. Happy to share more if you're curious, and with anyone here if you're curious. You okay? It's called Orbit Neuro, or it's a startup. They're just getting started, so it should be available in the near future.
Yeah, I can say a little bit about this because this is related to some research that we do. Over the last several years, as part of a large consortium across the United States, we have been studying brain electrophysiological signatures using EEG across psychotic disorders. schizophrenia and bipolar disorder and schizoaffective disorder and so forth. What we have found very interestingly is that based on EEG, one can classify psychosis into three categories. One with a deficient functioning of neurons, another one with an exaggerated overactivity of neural systems to stimuli, and a third group which does not seem to differ from healthy people. And so we call them biotypes, biological type, biotype 1, biotype 2, and biotype 3. Our data seems to suggest that, biotype 1 might be the one that potentially might respond to clozapine better than the other biotypes. We are currently testing that hypothesis in an ongoing study. So we'll know the answer to that within the next 2-3 years. But the question you ask is a very important one. What we do are EEGs and other biomarkers in an academic facility where there are, the resources for doing a thorough EEG with 24 leads, which requires a lab. But what you're suggesting is doing that at home with 2 leads, maybe on a tape, something, like a headband. And those technologies are available. They're not sensitive enough. They're not detailed enough to, get to be clinically useful as yet. So that day will come, probably in the not too distant future.
And there are similar studies with bipolar. Those who have a positive EEG respond better to Depakote. Those without the EEG abnormalities are better with lithium. Okay.
I guess Nicole, would you like to figure out who goes next?
Yes, I was on my way.
Hello. My question is, you said that people with schizophrenia, after every relapse, it causes brain damage. But what if the person continues taking their medication, but they relapse on drugs and alcohol, and it affects the efficacy of the medication?
Yes, unfortunately, that's true. Many of my patients would be doing well, and then they get into marijuana, especially, and that can cause a relapse despite the fact that they're taking medication. So I warn them, it's like kryptonite for Superman. Marijuana is kryptonite for schizophrenia and bipolar disorder. But there are people who also relapse despite 100% adherence, and those are probably treatment-resistant patients that need clozapine. No studies have been done on that, but drug abuse in general causes brain damage, toxicity damage, different than the apoptosis. That is a different kind of damage than schizophrenia. Yeah. Please don't drink alcohol. It's really bad for your brain. I'm serious. I mean, people think one glass of wine a day is okay. The research shows that even 1 drink a day can be toxic to the brain. It's too bad. Yeah, but
My question
Hi there.
is,
Oh, sorry.
I'm curious. I have a couple of people in my area that I provide peer support to that are both spouses. And in both situations, they have had a spouse that didn't have anything remarkable in childhood. They've started families with both of these individuals, and nothing remarkable has happened throughout the early course of their marriage. And then right around 40, one is a male and one is a female, they have developed symptoms of psychosis and the whole family is falling apart. And my question for you is, we talk a lot about all of this starting early on, but nobody, or I won't say nobody, rarely do I hear about if this happens like in a late onset type situation. And in both of these cases, they appear much differently than I see in a younger demographic. So I guess my question is, what differences are there when there's late onset versus early on?
You have a shot on it. I mean, we know that typically psychotic illness does present in young adulthood, and that's a typical course, but there does tend to be this second wave. Sometimes women around perimenopause or menopause. I believe there's a second wave for men as well. I'm not as familiar with that specific type, but perhaps something more hormonal, something related to that. Dr. Keshavan, Dr. Nasrallah, do you want to add anything to that?
I just want to add the following, that post-menopause, when a woman who inherited genes for schizophrenia, she has genes in the family, she has psychosis in the family, and she's not psychotic in their 20s or 30s or 40s. Once she goes past menopause, the rate of psychosis goes sky high, because estrogen is an antipsychotic, and it protects women while they are in the childbearing years. They're producing a lot of estrogen, but once you go into menopause, unfortunately, then they develop full-fledged schizophrenia, far more than men. Men get it early in the teens and 20s, and women get it in the 30s, 40s, but then another peak in the 50s and 60s. Want to add anything?
What I would like to add is that, you know, schizophrenia is not one condition, it's a collection of multiple illnesses. And someone who develops this illness after age of 40, we typically think about other conditions like neurological conditions that could contribute to this psychosis. And someone with an onset after 40, I would ask for a full workup, a neurological medical workup, including brain scans and EEG.
Yes.
My question, my name is Leaf. My question is, now you seem to all support long-acting injectables. I'm on one, and I think it's fantastic. I had heard at one point, and now I don't know if it was true or not, that there was some ways to make other medications, like I have schizoaffective disorder, bipolar subtype, and so I take a mood stabilizer and I also take antidepressants. Are there long-acting injectables for some of these others so I can reduce the amount of meds I have to take every day?
The only long-acting injectable approved by the FDA for schizoaffective disorder is Invega. The others probably work too, but that company bothered to do the studies and it worked. I don't know, other companies have done studies for straightforward schizophrenia or straightforward bipolar, but not the schizoaffective. And we didn't mention names here in case you're curious about long-acting, but the very first long-acting second generation atypical is the Risperdal Consta. It was every 2 weeks, which makes it a little bit too much. So in 2009, Invega came to the market, same company, and Invega is the son of Risperidone. So when Risperidone goes through the liver, it becomes Invega. So that came out in 2009, once a month, and then later, in 2015, they developed once every 3 months, and in 2023, they make it once every 6 months. So that's pretty good for people who are homeless and they're not reliable. Once a shot can protect them for 6 months. And then Abilify Maintena, which is a aripiprazole, came out in 2015, once a month, and then the company did some studies for the FDA and came up with Asymptofy, which is every 2 months, approved for both schizophrenia and bipolar. All right. And then olanzapine was developed by Lilly, the same company that made oral Zyprexa. But because of the weight gain issue, not too many people used it, hardly any. It fell flat on its face. But as you heard this morning from Dr. Cotes, where's Dr. Cotes? Here you go. We've been using metformin for clozapine and olanzapine for a long time at the very beginning to protect patients from weight gain and diabetes, because that's the highest rate is in those two disorders. But a consensus conference of experts was published in Schizophrenia Bulletin a few months ago, highly recommending that when you start any atypical, not just olanzapine, clozapine, you should start metformin on day one to protect them from gaining weight, not give it to them after they have gained 20 kilos, which is like 40, 50 pounds. So then most recently we have subcutaneous. All of these were intramuscular, the ones I mentioned. In 2022, Uzedy came to the market. It's a risperidone subcutaneous, either once a month or once every 2 months. And the same company finished the studies, olanzapine subcutaneous. It's probably going to be approved, launched by the end of this year. And then there is another company called Luwei, it's a Chinese company that introduced Erzofri, which is really Invega under a different name, but they had a higher dose, just one dose in the beginning instead of 2 doses. Yeah. So I think I covered the name in case you want to recognize them at some point.
Great,
for
thank
your
you.
kids.
I just wanted to add, Dr. Nasrallah, no offense to your colleagues, but if I were an American, I'd want you to be my psychiatrist.
All right, other questions?
Just a question to follow up on the marijuana. I'm wondering, are there any movements led by doctors to get labeling put on these products? You know, just like we had with cigarettes, they didn't put labeling for decades, and they knew that it caused cancer. But it took that long to get through the people that are lobbying for tobacco, et cetera. And now, we know this about marijuana, and it just seems like, nobody's doing anything about it. But it should be labeled.
I don't know specifically if there's doctor-led movements, but I practice in Massachusetts, and there's a huge movement right now to de-legalize marijuana again, just because of all the mental health issues it's been causing. I don't know if, I don't know specifically where the medical community stands on that, but the comparison that I've heard is that cigarette smoking is to lung cancer as marijuana use is to psychotic illness. So this is clearly something that after moving from Kentucky, where cannabis is not legal, to somewhere like Massachusetts, where it is, it's you can see the massive effect it has on mental illness and the mental health care system.
I just want to add to that, Linda. I appreciate the question, and I want to really applaud everybody that's spoken so far at CURESZ about addressing the cannabis problem. I track legislation for the Treatment Advocacy Center across all 50 states, and it's just incredible the number of bills that are moving in both directions. More legalization, more potency control, getting those THC limits down and everything. I will say that we really could use more definitive research to help support the education that needs to happen and to support the need for the labeling. And all the education that you're doing is really wonderful, but to any other psychiatrists and mental health professionals in the room, we need you on the game too. It can't just be moms and dads and family members doing advocacy across our country. We need all of you.
Yeah, what I would like to add, the research is there already showing the connection between marijuana and psychosis is without doubt at this point. The two other things that you mentioned, education and advocacy, especially advocacy, is critically important among many stakeholders, because the reason why so many states are delegalizing marijuana is because of many vested interests, businesses, and so forth. And so, organizations such as this should really come together to make a push at the legislative level to put such a label on marijuana.
I frankly think the genie is out of the bottle. Unfortunately, now one state after the other started in the West and moved to East, including Ohio, and they legalize it with no scientific input, purely political decision to collect some additional taxes, and that is so cruel to people who are vulnerable. And there are a lot of people vulnerable to bipolar and schizophrenia. Both of them are going to fall off a cliff when they use marijuana. And the dose, of course, make a difference. The higher the dose and the more intense some of those newer formulations, the higher the risk. And so anybody with a family history of psychosis, bipolar, schizophrenia, or frankly other things as well, should never touch the stuff. But it's hard to convince those young people because hey, everybody's using it. It's legal, right? And they don't know the risks that's going to ruin their life. So you're right. We all have to fight this. But unfortunately, it's so hard to undo what has been done.
Especially the observation that risk for psychosis is highest if the exposure to cannabis is during adolescence. And that is a strong case for increasing the age limit and, just like in alcohol, if there is a way in which that could be regulated, that would be a great step forward. I'm convinced, as Dr. Cotes was saying today, that family members and people with lived experience coming together can make a big difference, just like in the REMS system. And so this is another one of those.
And I do want to remind all of us that we, the taxpayers, pay the cost of an inpatient hospitalization and long-term, and disability payments and so on. So the bulk of the cost of psychosis, all types of psychosis, is borne by the taxpayers. And so we really have a vested interest in reducing the cost of mental illness by avoiding unnecessary relapses, so that we can maybe our taxes can be used for a lot of social programs, health programs that are going underfunded. So it's a message that we hope to disseminate in the public at large. But we need some powerful legislators, senators, and Congress people who have mental illness in their family to adopt this as a cause. Otherwise, we don't have the bullhorn.
Thank you. Could you speak to the use of fluvoxamine as an adjunct medication and also the long-term use of gabapentin?
I think Dr. Laitman, you should take a stab at this. Dr. Laitman is a great proper advocate of using fluvoxamine.
I just called my Uber, so I'll be brief. You have to have extreme care if you're going to use fluvoxamine. I started using fluvoxamine only when I couldn't get adequate clozapine level in young, not surprisingly, white males who would smoke 2 packs of cigarettes a day, and I couldn't get them to stop smoking, and I just couldn't get levels. So I gently and carefully added fluvoxamine, and it definitely has a role there because they were just subtherapeutic. Having said that, I've also used it in settings where I've had a lot of issues with pneumonia, because what happens is at night you can change the ratio of clozapine to norclozapine. Norclozapine is the first metabolite from clozapine, and that primarily will increase a lot of the siluria. So you'll have much less saliva at night. But again, you need so much care. Your psychiatrist, whoever you're working with, has to be really expert, because I've seen it screwed up more than I've seen it done correctly. It's 6.25 milligrams, this tiny dose, and you check a level in a week. You go 6.25 again, and then this is therapeutic drug monitoring. You have to do this. Having said that, I have a number of people on the combination, and it works pretty well. I've definitely de-emphasized it. If you guys have read my initial books, if you get edition 5, it's really a much smaller part of what we do. It's a tool, especially if you need very high levels. Someone who's sicker longer and hasn't been responsive, and you're going to push beyond what are considered traditional levels, because then you have clozapine and norclozapine both contributing to side effects, and you have less norclozapine on board. This is presumably, this is the mechanism. As we've already said, what do we know? So it's useful, but with extreme care. Okay.
Let me elaborate on the extreme care part, Bob, because that's right. Historically, Luvox came into the scene as a way to combine it with clozapine back in 1990, 91. Clozapine was approved by the FDA in 89, and it was very expensive, extremely expensive. So somebody came up with this brilliant idea that maybe if we use a lower dose, because the cost was proportionate to the dose, maybe if we can afford a smaller dose, we combine it with Luvox. Luvox inhibit the metabolism of clozapine in the liver so that it stays in the blood longer. So they didn't do any studies back then. They just haphazardly gave doses of not 6.25. They gave 100, 150.
No, 50 milligrams will traditionally, in most patients, triple your doses. And if you start at a dose like that, you're going to do significant harm. rather
Yeah,
than
they could death, including death. There were
well,
reports of
very
death.
much harm,
Right.
yes, permanent harm. So you really, that's what I mean by extreme care. Every time you go up, you need to check the dose. And there's a lot of controversy about clozapine and norclozapine and ratio and who has the best cognition. And it goes back and forth. Lou's done a lot of work in Taiwan. And I certainly have a cohort, probably about 70 patients or so that are on this combination. But I have several hundred patients, so it's really a minority altogether now. And again, it's a tool, but the bottom line returns. Use clozapine, listen to Rob Cotes, moderate the side effects, maybe go a little slower than Rob said in the beginning, but beyond that, it was practically perfect. Okay.
Hi. Thank you for your talk here. I have a question more. Oh, sorry. I have a question more about sort of social supports. So, okay. Yeah. So I have lived experience and I'm also a clinical social worker. And I've worked in public housing in Queens for supported housing units for folks with schizophrenia diagnoses, bipolar, and so forth. I'm wondering what sort of community supports need to be in place in order to assist people without any family support in achieving meaningful recovery. I've seen that when people don't have those supports from family in place, they become reliant on the public services they receive in order to reach recovery. And that's a much harder journey I've seen. I'm wondering if you can speak to that experience and some solutions.
Yeah, I mean, I think there's so many needs for someone who has a chronic, sometimes debilitating, increasingly progressive illness. Obviously, you're going to need a lot of help along the way, and without family for some of that to fall on, you really do have to kind of spread the work around. And what does that look like? Practicing in Massachusetts, we have a lot more of a social infrastructure to assist people. ACT team models, which I know are a nationwide thing, are super helpful. People coming to your home, making sure that your needs are met, making sure that you're eating, bathing, taking care of your ADLs, having a visiting nurse assistant or visiting provider who is ensuring you're taking your medications. If you're on clozapine, hopefully having like a point of care blood check to monitor your ANC. But I guess, do you all want to add anything else to that? But yes, I think in general as a society, we just don't put resources into that sector as much as we should. And it's quite tragic. And it's something that, I certainly haven't figured out for my patients and also breaks my heart, to be frank with you.
What I would add is, obviously, as Dr. Good said, there are state-to-state variations in how much infrastructure exists for support. I would recommend you look at a book called You're Not Alone by NAMI, which has a set of these kinds of resources at the end of the book, and the numbers to call and so forth. Yep.
Couple more questions?
Yeah, keep going. We have time.
Okay. All right.
Thank you so much for all the talks were great. I'm a family member.
Can you get it closer to your mouth?
Hello, can you hear me? Yes. So Dr. Nasrallah, you have partly answered the question that I was going to ask. And the question is, whenever a patient gets a relapse, brain tissue is damaged, right, by 12 cc. So if your loved one is in persistent psychosis, despite the treatment, are they losing the brain tissue throughout all that time that they're in psychosis?
Does psychosis continue to cause brain damage? I would say, and I would be interested in Dr. Nasrallah's opinion on this as well. I would say that The answer to that question is at best controversial. There is no, convincing evidence that psychosis, in and of itself, is neurotoxic in a long-term basis, and certainly some indications point towards that. But I would say the answer is not definite, because there are patients in whom, after persistent psychosis, when they get better, their brain function appears to come back to normal. This is my clinical experience. So simply to say that psychosis itself is neurotoxic, I think we need more data on that.
Yeah, and to be scientifically fair, because schizophrenia is a heterogeneous syndrome anyway, numerous subtypes, there is a subtype where there is no toxicity, and we don't know why some psychotic disorders, psychotic variants are toxic and others not. And this was shown in a paper published like 20 years ago, where there's a group of patients where the psychosis led to a steep decline in brain volume, but there's a subgroup that did not have a steep decline. We don't know how to predict it, but usually, clinically, the earlier the onset of schizophrenia, the worse the brain toxicity from psychosis. The later onset, which tends to happen more on females, by the way, males get the worst outcome, so they get more atrophy. This has been shown. Gender difference, males get more morphological brain changes in psychosis compared to females, but females have later age of onset compared to males. So it's probably related to the aggressive neurodevelopmental onset of illness in 15, 16, 17, has a worse toxicity with psychosis than those in the 25 to 30 and higher. And the absolutely worst brain changes occurs in childhood schizophrenia, which is before age 12. This is the worst form, and the only drug that comes close to helping is clozapine. Nothing else works, and even clozapine barely controls them, because that is a very aggressive genetic expression coming out at very early age. So again, like to answer your question, there are variations, but in general, the majority of patients seem to risk neurotoxicity, and that's why we need to prevent it from going. The duration of untreated psychosis, DUP, is a very well-known concept, and it's associated with worse outcome.
Yeah, so one other angle to that question, which is a very important debate in the field, is first of all, there are some studies which show that people who are treated with long-term antipsychotic medications have thinner cerebral cortex. Now, there's a problem with simply making a conclusion that antipsychotics cause that, because those who have a chronic illness end up requiring more antipsychotic drugs. It's not that the antipsychotics cause the brain thinning there, but it is the underlying illness itself. In fact, the idea that it is the illness and not the medications causing that brain changes was supported by a study which showed that it is not the duration of time on antipsychotics that was related to the cortical thinning, but it was the amount of time that they had relapsed and that they were off medications. So psychosis itself could be neurotoxic, but medications could have their effect, but the distinction between what causes the brain thinning is not at all clear. So, but on the other hand, one more angle, which is that there are some studies which suggest that, and Dr. Nasrallah has written about it as well, that antipsychotics may even be neuroprotective. So he pointed out how prolactin elevation could actually rebuild, myelin neurons and so forth. So this is an area of research. We don't have very good answers yet.
Just to build up what Dr. Keshavan mentioned, the drugs, the first generation antipsychotics definitely cause atrophy. This is shown in a mass study, meta-analysis of 18 studies, patients who were maintained on first generation versus second generation. There's clearly a reduction in brain volume, those maintained on Haldol and Thorazine and L'Occitane and Prolixin and those drugs. for a period of time compared to those maintained on one of the 11 second generation drugs. No change, hardly any change in brain volume. In fact, it grew a little bit in parts of the brain. So I published one article about 32 studies showing toxicity of the first generation drugs, Haldol and colleagues, and another paper, the neuroprotective effects of second generation. 24 studies showed 24 different beneficial effect in addition to the antipsychotic effect, rebuilding the brain and neuroplasticity and antioxidant and anti-inflammatory. So the second generation are clearly safer, and that's why I never use the first generation anymore. I used them in the past; they work, but we didn't know that they cause some negative brain changes, so as to speak.
Just one additional caveat that I want to mention in regard to this very important question. The brain changes that might happen in the long-term course of these illnesses may not necessarily be either related to the psychosis or the medications, but more because of the negative symptoms. If they are sitting in the basement and not doing anything and they are not cognitively challenging themselves, that itself would lead to what we call disuse atrophy. And that is something to be considered seriously, because approach to management here would be not just medications to control their psychosis, but actually rehabs, psychosocial interventions to improve their activity back to normal life, getting them out, physical exercise, socialization, all of those are very important.
I don't think my last presentation is going to take 35 minutes. Do we have more questions now?
There's
Okay.
2 questions there. Three names.
Nicole, where do you want to start?
Hello.
Crystal.
Thank you. So I have a question. I worked at the Arizona State Hospital for 30 years and fought against the anosognosia. You guys have just a lot of new information, and I'm wondering if I also raised 2 kids with autism, and so I'm very curious if there's anything with anosognosia that you've noticed that ways that we can, I think, build different neural networks in order to, like, it's almost like you can't fix it, but you can educate and teach it and have it kind of like an autism where you build different connections. Is there anything new on that and how it relates to schizophrenia?
Anosognosia exists in several other disorders, by the way. It's all published. It's worse in schizophrenia, proportionately. But bipolar mania, absolutely, they don't believe they're sick. They're, hi, I'm great, I'm productive, I'm thinking clearly, I can exercise 10 hours a day, etc. So they don't think they're sick, and it's almost, it takes an act of Congress to convince the bipolar manics to take a medication. But also, people with depression and OCD and eating disorders have been shown to have anosognosia as well. The part of the brain that has been shown to be responsible for loss of insight, lack of insight, is parietofrontal. That part of the brain represents who we are, and it makes you, all of us in this room, know how we are doing physically, mentally, socially. We're aware, okay? And those brain regions make us aware of our life, our existence, our state of mind, and physical state as well. Patients with schizophrenia have a disturbance there, but the good news is that it does come back eventually. And I don't know if it's due to the antipsychotics, but I think a period where an absence of delusions, hallucinations seems to predispose to improvement. Cognition, social cognition is associated, disorders of social cognition, I don't know if you know the difference. Neurocognition is a memory, concentration, focus, etc. Social cognition is poor social skills. They cannot read people's faces. They cannot recognize tones of voice. They cannot recognize gestures. And so those are the kind of negative symptoms that are more associated, and cognitive deficits more associated with lack of insight. And there are actually there's a type of psychotherapy that's specific for anosognosia that some psychologists use as well.
Yeah, I can say a little bit more about that. As Dr. Nasrallah said, anosognosia is related to cognition, but it is related to one particular aspect of cognition, which is called metacognition. So, that is about thinking about thinking. If the person is able to self-reflect observe one's own thoughts and emotions and not judge them, but observe them and let them go. That is called metacognition. And the form of psychotherapy that is being called is called merit therapy, which is available now, and many institutions have people skilled in that. It is metacognition, reflection therapy, metacognition and reflection therapy, merit. It was developed by Paul Lysaker. So that's one psychotherapeutic approach. The other thing I want to add is that lack of insight in stroke, in neurological disorders, tends to happen more when the brain lesions are on the right side, because it's the right hemisphere in right-handed individuals, which is the observing brain, whereas the left hemisphere is the acting brain. So in stroke, when it affects the right hemisphere, in other words, they have the left-sided paralysis, that is what causes anosognosia. In schizophrenia, there is some data, including our own, which were published, that anosognosia is related to right prefrontal and frontoparietal structural alterations. So why is that important? The importance may be that there is another potential approach to treat anosognosia by stimulating the appropriate brain circuits using neuromodulation like TMS. And there are some small reports that have emerged suggesting that insight might improve with neuromodulation, which is selectively localized. But that's still in its beginning, and we don't have replication of those findings, but there's something to consider going forward.
I want to add something to that. Dr. Keshavan reminded me. I just saw a study recently, a few months ago. ECT regained insight temporarily. Patients were given ECT, severe schizophrenia. By the way, ECT is a very good treatment for schizophrenia. When clozapine doesn't work, that's the way to go. A recent study showed that even before clozapine, it significantly reduces the rate of relapse as well. But ECT is a neuromodulation technique, like Dr. Keshavan said. And that case that I read, patient had no insight whatsoever. ECT was given for schizophrenia, psychosis improved, and the insight came back rapidly after the ECT. So perhaps stimulating that part of the brain works. Now, I want to remind you about Dr. Babinski is a neurologist who, 100 years ago, he noticed that patients who had a stroke in the left side of their body, which means the stroke happened in the right hemisphere, they could talk. The left hemisphere is not intact, so the patient can talk to the doctor. And he asked them, "What's wrong with your arm dangling, paralyzed?" "Nothing. There's nothing." "Well, it sounds like you can't move it." "No, I just don't want to move it." Patients with a neurological deficit due to stroke have anosognosia. That's how the term came out from that. So basically, there's no way antipsychotics regain insight, but neuromodulation may actually work. And we didn't talk much about ECT here, but if you have loved ones who don't respond to clozapine, treatment-resistant patients, ECT works quite well. And it basically rebuilds the brain. The brain grows 10%, certain parts of the brain grow 10% in 2 weeks after ECT. That's unbelievable that this organ can be grown that fast with neuromodulation. So don't hesitate to seek ECT if your loved one does not respond to anything, including clozapine. Clozapine works only in about 45%. So you have 55% of patients who may need ECT. Okay.
Something. I want to make a pitch for ECT a little bit further. It's probably the best treatment we have in psychiatry, but again, underutilized. I think to a large extent because of the stigma attached to it. The stigma comes from the name electroconvulsive therapy. So there is this scary imagery that shock treatment and the convulsions and so on. But we now know that you don't need convulsions to produce the therapeutic benefits of ECT. Anesthesiologists, they administer anesthesia and then there are no movements. There is no convulsions. So we have actually stopped using the term ECT in our clinic. We have a neuromodulation division in our Department of Psychiatry. ECT comes under that. And we don't use the term ECT, we call them the best treatment. Bilateral electrical stimulation treatment. That's ECT. But you can also use unilateral ECT, which may have some less of side effects. So, but I would encourage people to consider ECT.
We have our IT guy raising his hand. That's making me nervous. What's wrong? Your testimony? Probably not at the moment, but I can talk to you afterward. We'd be happy to follow up. Yeah, thank you. We've got time for either two quick questions or one long one.
All right, Bethany, he's been waiting a long time.
Thank you. Thank you for
Okay.
thank you for speaking about ECT, because I think that's a good treatment that we're actually debating from Clozapine if the Clozapine doesn't really do its work.
You need to be here for.
So the question I have for you, doctor, so a common symptom to all these mental illness people, including my son, is voices as well as delusion. Clozapine is helping, but the voices is there. And just like this young man said, hey, how do you stop it, right? And my son is asking, I need these voices to stop. How do I stop it? I'll do whatever it takes to stop it. So the question to you is, what other medication do we add to Clozapine to hopefully help that? Or do you recommend increasing the level to hopefully get that taken care of?
Yeah, so my own experience is that when Clozapine is not working, adding a second antipsychotic may be modestly helpful, but the results are not dramatic. And I would use a standard dopamine blocking agent like risperidone. I also used aripiprazole for that purpose. But I strongly believe that you should consider ECT. And in fact, I have patients on maintenance ECT getting once a month and along with Clozapine, and they're doing just fine. Not completely fine, but yeah, it is the best we have.
There is, speaking of voices, though, for those who improve in many ways, but the voices continue, with Clozapine, there are several reports in the literature about deep brain stimulation, DBS, which is focused on the temporoparietal area, and it shows significant reduction of the voices with DBS. It's experimental, it's not approved, but it's being done on a research basis, which is promising. It shows that you can suppress them with a localized DBS in certain parts of the brain, which are involved in the auditory pathways. Yeah.
All right. Are we done? Do we have one more quick question, perhaps?
I'm going to ask the audience something, if you don't mind.
Yes.
How many of you have seen One Flew Over the Cuckoo's Nest? Raise your hand. That was the worst movie ever for psychiatry, because it portrayed ECT, like Dr. Keshavan said, as the most horrendous treatment ever. Nobody wanted to touch it, but it was really portrayed in a very dramatic and archaic form, like they used to do it in 1930 and 40. Of course, now we do ECT. The patient basically gets an injection of a medication that paralyzes the body, so they don't move. They get a seizure without moving whatsoever for 30 seconds, and they wake up and go and have breakfast. It is a very humane and easy treatment to give. So don't be afraid to refer your relative to ECT if they need it. It really is a wonderful treatment. I have patients who are 90 years old with severe depression, and give them ECT at that age with excellent response and hardly any side effects.
A question to the audience, last question. So I understand yesterday there was a active discussion in this audience on naming of schizophrenia. And in fact, some people came and asked me to bring it up if that's possible. So I have done some research in that area myself, and there are a number of organizations that are interested in that question. But I want to ask all of you, raise your hand if you believe that the name schizophrenia should be changed or not. I see that's almost the majority.
Very inconvenient for cures.
Well, we can come up with a new name for cures.
Well, just to follow up, a huge effort is being invested by an international group, and we were just talking about it yesterday at the colloquium. That definitely the majority of schizophrenia researchers in the world want a different term. But surprisingly, you did a study, Dr. Keshavan, where patients, quite a few group of patients said, no, we don't want to change.
74% in our study said change the name.
Yeah, but then some said, okay.
Yeah,
So you don't think it's Concorde, like the jet Concorde. Yeah, it's a combination of cognition, conation, and the reality distortion, which I think is a great way to change the name of psychosis. Reality distortion is delusions. You misread the world in a faulty way, but you know, I don't know if anybody's going to adopt that, but it's a neutral term and descriptive and accurate. Reality distortion. Brain attack, that's acute psychosis, yeah. And, you know, since we talked about excitotoxicity, I did not mention it. There are quite a lot of studies done by academic psychiatrists, not FDA studies, showing that omega-3 fatty acid is a very good anti-inflammatory agent. So it reduces the inflammation, which is one of the toxic processes during psychosis. And then N-acetylcysteine, NAC, is an antioxidant that neutralizes the free radicals. So when a patient is acutely psychotic, first episode, I would add those two, even though they're not approved by the FDA, but they're supplements. You can buy them from the health food store to reduce the impact of inflammation and free radicals during the acute phase. NAC? What dose? Oh, 600 milligrams once or twice a day.
I think we should probably move on.
Mr. Stagland has a question.
Mr.
Stagland? Bethany, Mr. Stagland has a question.
How many people are not in favor of changing the name schizophrenia? 2 people.
There's a few people.
Yeah. I think Brendan has a point that any name could get stigmatized over the course of time. You know, I think the critical issue is developing better treatments, and then the stigma will go away. But on the other hand, at this time, the prevailing opinion, I have to say, from studies and from this audience, is that maybe it's time to change. My own view is a bit more cautious. We have to revise the concept of schizophrenia, and the name, appropriate name, will automatically declare itself. So we'll see.
Yeah, Japan already in 2016, the Japanese Psychiatric Society decided to change it to integration disorder. And, you know, families coming out of the woodwork, bringing their kids because it's less stigmatized. Stigma is big in the Orient there. And then Taiwan and South Korea also changed the name to attunement disorder. I don't know where they came up with that. But again, it's different than schizophrenia. And they say that people were more likely to come forward for treatment.
I had suggested the name thought and perception disorder, which seems like a fairly neutral, non-stigmatizing name to consider.
Are we done? Are we ready to wrap up here? So, yeah. You know, I am just amazed. When I look back, I thought I was one in a million. I was the only one going through this. And I mean, I am a little bit unusual in the extent and duration of my homelessness and living outside. But, you know, today, CURESZ is offering hope to people who are doing the very worst. You know, we're offering hope to people who have had 10 hospitalizations. We've talked about our book Awakenings before. One of the women in our book, who is an artist, she's had over 100 hospitalizations. So, and she's featured because she's been married, she's a professor, and she owns a home. We are here to take the most hopeless cases there are, the most treatment resistant. And we are so proud to connect the families we serve directly with people like Dr. Nasrallah, Dr. Keshavan, Dr. Good, and other members of our foundation. So there is hope even for the sickest of us. That's me with Dr. Nasrallah. As we said before, my book came out in 2014. When Dr. Nasrallah first brought up cures, it was actually a family joke. We said, right, we're really going to do that, sure. So yeah, it's amazing today to think of 10 years. All right, I'm not going to tell you about Clozapine, but I will tell you on our website, you can find almost anything about Clozapine, including our Clozapine and schizophrenia expert panel. We have about 140 clinicians. We have mostly psychiatrists, we have psychiatric nurse practitioners, and we have some pharmacists who are on this panel too. I would like to expand this panel. I would really like that a lot. So if any of you have a doctor, nurse practitioner who's prescribing your Clozapine, please do feel free to invite them to contact us to join the panel. We'd be very grateful for that. We have Clozapine videos. We used to have a guy named Louis Cady on our board, and I went to Indiana years and years ago. I think it was 2018. And recorded a series of 3 videos on Clozapine. I very highly recommend them. We also have a podcast by Dr. Jonathan Meyer, who used to be a board member on Clozapine. He talks about titrating it up to, in some cases, 1,000 milligrams a day, and of course, getting levels. He talks about ECT. I talk about this podcast constantly. So any of you, you're very welcome to check that out on the Clozapine page. Clozapine is not for everyone, as we've been saying today. Long-acting injectables are. These can be given to anybody. And as Dr. Nasrallah was saying, when they're given in the first episode, there is the most hope for recovery, hope for the future, going right back to school, right back to work, right back to relationships. So we are doing everything we can to get more people on long-acting injectables as soon as they can. And Dr. Nasrallah and I, as you see, this is a video. We did a 4-part series some time ago on LAIs. You know, also, if you look at Awakenings, it's 3 parts. It's a collection of essays I wrote. It's 28 recovery stories. And it's articles, many on Clozapine LAIs and also Tardive dyskinesia medications. I'm grateful for Dr. Nasrallah's excellent presentation on TD. I will say this. I know a doctor who says, I'm bald and I hate being bald. But when I go to my doctor, my family practice physician, I don't mention it because I know that there's nothing that can be done. This is how tardive dyskinesia used to be. People would come into their psychiatrist's office, they're doing this, if you can see me, this, look like they're opening and closing their mouth, chewing hard candy. The psychiatrist would do nothing, and sometimes if they took them off the antipsychotic, the TD would get worse. In my opinion, VMAT inhibitors, these medications to treat TD, I think they're one of our biggest advancements in decades. So we need to spread the word. TD is very underdiagnosed. TD treatments are very, very rarely prescribed. They say that we have a little less than 1 million, about 800,000 people with TD. Probably not, probably really a lot more. So we need to get a much better picture of how many people there are suffering from this, and we need to get these people on medication sooner rather than later. So those are our 3 big cutting edge underutilized categories: Clozapine all by itself, LAIs, and TD meds. And we're a big proponent of anything new and cutting edge, which is why we presented Cobenfy to you today. Anybody know about the CSARs? Have you seen this on our website? Just a handful of people. This is one of Dr. Nasrallah's brainchildren, cognition self-assessment rating scale. This is not the same as a full battery of cognitive tests, which can take 6 or 8 hours. But if you take this 5-minute assessment online, you may discover whether or not you actually need a full battery of cognitive tests. It's very easy. You answer 12 questions, it gives you a score. Check it out. It's very easy to find on our website. We showed you this video before, schizophrenia, treatable biological syndrome. So I hope you enjoyed this video. Please feel free to share this video. We'd love to have more hits. When I was diagnosed, as I was saying before, I didn't know anything. And so we put together the treatment checklist, 9 things to know. As you might guess, of course, we have clozapine LAIs and VMAT2 inhibitors, cognitive behavioral therapy counseling, diet and exercise, supplements and vitamins. So really important things that everyone should know. Another 2 things on the list are learning about schizophrenia and making goals. I remember when I was not yet on clozapine, my dad, I was on risperidone and it helped a lot. I was very spacey and drugged out. It was not the best drug for me, though it works for many others. But Dad and I went to the University of Cincinnati and we met with a guidance counselor and we talked about me going back to school. And it was a little bit hard because I was like, I'm probably more likely to go back to school, or less likely, I should say, than taking a rocket ship and going to the moon. Didn't feel possible, but when I got better, I was more ready to go back to school. So I think it's really important to make easy goals 1 step at a time and also ambitious goals. And Dr. Nasrallah always encouraged me to shoot for the stars and dream big. So let's do that for our loved ones with schizophrenia. We keep talking about day 0 today. I think all of you have gotten a flyer with day 0. Once the summit is over, Nicole and I and our great graphic designer who's here, Eric Ayler, we're going to get very busy and we're going to create a paperback resource for day 0, probably a folder. It's going to be warm, it's going to be colorful, it's going to be inspiring. And we are thinking about maybe sending a box of stuffed animals to hospitals to distribute this. I don't know. We want it to be really warm. And we can't give everybody a candy bar and a balloon, but that's how we'd like them to feel. If you leave the hospital after a breast cancer surgery, you know how much support they get. They get casseroles and gifts and cards and everything they need, resources, pamphlets. We need to do the same in schizophrenia. So we're going to be really working hard to develop the best day 0 toolkit we can. And if we're as successful as we hope we'll be, maybe we'll get this all over the country. And maybe some of you or all of you can help us distribute this. You probably all or most of you have gotten our newsletter. It's a quarterly newsletter. You can subscribe online. You can also give us your address. We're still sending them by old-fashioned snail mail. That's one Dr. Rush, who's a board member, did on suicide. We did one article on psychotherapy. This guy, young doctor, was excellent. You probably have seen I have a TED Talk. It has about 350,000 views. I did not hit 1 million. But you're welcome to check that out as well. This is our YouTube channel. We have about 85 videos. We actually also did a cognition and schizophrenia series with Philip Harvey years ago. And when we do our CURESZ Clubs virtual lecture series, a lot of those videos will pop up on our YouTube channel. So check us out. We'd love for you to subscribe. We're at about 2,500 subscribers, so hopefully that will continue to grow. A few more of our programs just to close out. Ask the Doctor or Ask the Expert events. All of these clinicians, most of them on our board, have hosted Ask the Doctor. It's 90 minutes for only 6 families to ask one of our experts anything about brain disorders. It's once a month. We encourage a donation, but we welcome anybody regardless of what they can give. So this is another service of the CURESZ Foundation that we're really proud of, giving people attention, the most cutting edge information, the most experienced clinicians. So yeah, so sign up for Ask the Expert. I think our next one is with Dr. Cotes on June 29th. We talked about our mentoring program. That's actually the landing page. And Mary Beth, who stood up and asked about the program and gave a bit of an update on the program, she actually founded that in 2020. So we're still really grateful to her and proud of our program. If you are a schizophrenia survivor attending the conference this time, would you mind standing up? You know, when I was diagnosed with schizophrenia, I didn't want to know anybody else with schizophrenia. I didn't want to be in a support group. I envisioned a support group as a place where people were all sad and depressed and talking about how they'd never get better. And I didn't want to have anything to do with that. But when I started Cures, I started meeting these amazing people, these people who just stood up. And I could not believe how much we had in common. And many of you who just stood up have become really wonderful friends to me. And I just want to say I am so honored to have you in my life. And the Cures Foundation, all of us at Cures, we thank you so very, very much for letting us feature your story online, most of you in Awakenings. We hope to keep working with you. As I said before, Leaf is one of our ambassadors. We're hoping many more of you will stand up and help me go into the community, educate on schizophrenia. Again, thank you all so very much. Here's Awakenings. We have copies in the back. I've talked about that a lot. Share it with friends and colleagues. And I think that that's pretty much everything we do, except for one thing that I don't think came up, our support group. So Cures has two support groups. We used to call one of them the Advisory Council Support Group, and then everybody said the name was too long. But we called it that because on every support group, we had a handful of advisors, including Leaf and Chelsea, who just stood up. We have, I'm sure I'm forgetting others, but some of our survivals were joining these support group calls. Every support group call on Sunday night and the ones we have now on Wednesday night, they include people in full recovery. I forgot to mention Daryl Herman and Kristen Herman. They are both in full recovery too, and they often join our calls and give excellent information. But yeah, if you're looking for a support group that's very hopeful, information, support, it makes you understand that you're not alone. If you're looking for a group like that, please contact us. You know, maybe it's time for us to even start a third or a fourth support group because they're going very well. So that's it. Let's see what time it is. It's 2:30. Dr. Nasrallah, would you like to come up here and help me close the meeting out? If you want to make, I'll just say it one last time. You have the donations QR code. We'll put it back up on the screen, but we'll match them again up to $10,000. So thank you in advance for that. He'll say a few things and then I'll close us out.
Yeah. I mean, just by coming and joining us for this felicitous occasion is, to me, donation in its own right. Coming, spending time with us, we really appreciate that. Money always is good, but thank you so much for your personal support. I can tell that you're invested with us. We love you as well and want to serve you. Bethany and I do this as a labor of love and totally dedicated to patients suffering from schizophrenia. They really deserve much more than what they're getting. But we also really appreciate what the families are doing. The families who are here today are exemplars of the great families that stick with their patient, with their loved ones. I know many families that just basically get disconnected from their son or daughter, but you haven't. So that's a great sign. Thanks again for coming. And Bethany said it all. I don't have to go into any more details, but do you want to ask and say anything else besides?
Contact us. I got my lapel mic working. No, it's okay. Do contact us, get involved. We're here to serve you, and we're willing to do anything it takes to give you, your loved one, the very best outcome and sustained, stable recovery. So if there's anything we can do to make that happen, please let us know. If you have medical questions, don't hesitate to let us know. Again, we'd love to see you at Ask the Doctor. So just a few things as we close out. About 3 o'clock, 3:15, we're going to have two meetings. We're going to have a meeting for the Cures Foundation mentors. It's going to be in Findlay, which is on this floor right by the ladies' restroom, actually, if you know where that is. If you're a survivor, we're going to have a meeting in the Neil Armstrong room downstairs. And if for everybody else, like board members will be free, from 3 o'clock on, the big 0 room downstairs will be open, and Cody will be recording some testimonials. So feel free to take part in that. One last thing about parking. My mom, Karen Yeiser, can give you, she's back there. If she can give you a parking ticket and she will explain to you exactly how it works because it's a little bit complicated. Oh,
what is that?
we have popcorn. Okay.
Has nothing to do with parking.
Good. And return your badges if you don't mind back there. Finally, the very last thing we want to say is please stand up. My parents are already standing back there with Sonia. We want to thank Karen Yeiser, David Yeiser, Sonia Kirkland, and Nicole Gillen. Nicole was really amazing in the last few months. This wouldn't have happened without her. It would have been a mess. And there is one more person I'd like to recognize, Eric Ayler. Eric, are you here? Yeah, that's our graphic design guy. All right. Thank you so much. I wish you a wonderful travel home. Contact us. Yeah, thank you very much.